Yes, sir. I'll give the countdown. We are live in 5, 4, 3, 2, 1.
Good evening, everyone. We welcome you all to Ortho TV Online Spineconnect Season 2. To introduce today's topic and speaker, I hand over to the partner, Dr. Shailesh.
Thank you, Dr. Neeraj and Dr. Ashok Sham for Ortho TV. We welcome you all for the last episode of Spineconnect. And this is under the aegis of Maharashtra Orthopedic Association, Pune Orthopedic Society and Sancheti Hospital joint venture. The format of these presentations are slightly different than routine presentations, where we have more of healthy debates about various aspects in spine. And today the three topics which we are are TB spine surgery, anterior versus posterior approach, the implants, Indian versus imported versus hybrid. And this is again going to be a very important debate. And the last debate, which is the debate of only MIS or endoscopic or only decompression, debridement versus the completely thorough debridement and fusion in infective spondylodiscitis, TB or non-TB. So this is always a dilemma for all of us. And today we have a stellar faculty from all over India. I welcome Dr. Shinde sir as a president of Maharashtra Orthopedic Association to start the proceedings, and then I will introduce all the speakers. Yes, Shinde sir.
Good evening, dear friends. I, Dr. Ajit Shinde, President of Maharashtra Orthopedic Association, welcome you all to this Grand Spine Connect webinar series, session 2. Today here we are going to discuss about surgical management of infective spine, pathology focused mainly on TB spine. Spine has been a very dear topic for me since concepting my career in orthopedics. And especially the management of TB spine has been drastically evolved compared to what it was 30 years ago, when patient needed to be managed with prolonged breast immobilization and chemotherapy, thereby significantly affecting quality of daily living, that too with suboptimal outcome many a times. But now time has changed. To enlighten us more regarding current updates, we are going to have today triplet debates to clear confusion in mind of every young aspiring orthopedic surgeon all over state and nation. Debate 1, TB spine referred surgical approach, anterior surgery, Dr. Amol Rege versus posterior surgery, Professor Dr. SK Shrivastava. Debate 2, implant of choice, Indian, Dr. Rishi Kanna versus imported Dr. Kiran Lingutla versus hybrid Dr. Dheeraj Sonone. Debate 3, procedure prepared, minimal invasive surgery, decompression, Dr. Umesh Shrikanta versus fusion, Dr. Bhavuk Garg. I am sure these all masters will sportingly debate with each other, and all this academic quiz will be monitored by Dr. Raghav Datt, an ex-ASSI president, and my friend Dr. Shailesh Hadgaonkar. So without wasting more time, I hand over proceeding to today's moderator, Dr. Ranjeet Unnikrishnan and Siddharth Iyer, who are confused right now, but I am sure they will get enough clarity by the end of this session. Thank you. Jai Hind, Jai Maharashtra, Jai Moe.
Thank you, Professor Shinde sir, for a great support from Maharashtra Orthopedic Association and the organizing chairperson for the IOCON 2021. I would like to just give a brief about our speakers today, because I am sure most of the names everyone is aware of everyone. but still at least a brief for a lot of youngsters who are watching this program from all over the country. Dr. Raghav Datt is the academic chair for today's program. Dr. Raghav Datt is a senior spine surgeon practicing at Uday Clinic and in Hyderabad for over 30 years, and he is the ex-president of Association of Spine Surgeons of India. Dr. Raghav sir's great work is known for pediatric deformities, especially the early onset scoliosis, and we will be happy to see his views on all the aspects of spine surgery today as academic chair. We have our man confused with 15 to 20 years of experience, Dr. Ranjeet Unnikrishnan, the South Star, what we say, is from Trivendrum, and Ranjeet is practicing for minimal invasive to maximal invasive surgery, including deformity, degeneration, and infection, everything. As at 15-20 years of experience, I was discussing with him and he was talking, I'm still confused about certain aspects, and that is where we thought of sharing his ideas and understanding why he's still confused. And to burst the mystery of the confusion in TB spine, we have none other than Dr. SK Shrivastava, the honorary and head of the department of KEM Hospital, Mumbai, and one of the thorough gentlemen and academician India has got. We welcome you, Dr. Shrivastav, sir, for today's first debate. And we have someone to fight or someone to debate with Dr. SK Shrivastava is my dear friend, Dr. Amol Rege from Pune, who is practicing as one of the unit heads at Dinanath Mangeshkar Hospital. And Amol is also quite a versatile surgeon. He does a lot of interesting surgeries such as anterior surgery in TB spine, and his vast experience. We will have a healthy debate today. The second debate is again a challenging debate because at various places, because of different Indian economy, we have implants, and we always think about that this car is better, imported car is better, or Indian is also doing good. Even Tata Nexon is also doing good electric vehicle. Why we need a Tesla and all these things, similar things in spine surgery when we have good implants in Indian. What all things we see from their perspective, the challenging debate of Rishi Kanna, who is practicing as a senior consultant at Ganga Hospital. We welcome you, Rishi, for today's debate, and Rishi will be covering up or fighting from the Indian implants perspective. As in Ganga Hospital, they do mix of both, but they prefer a lot of Indian implants. And to have this debate more healthier, we have a guy who is fully trained in England, and he was a consultant in England, Dr. Kiran Lingutla, who is practicing as a senior consultant at Yashoda Hospital, Hyderabad. Welcome you, Kiran. And he has got a lot of international patients as well, and he has to deliver what they expect. Because he was talking to me and he was telling me in case the patient goes back to out of India, how he will have revision from this Indian implants. And these things were there where Kiran has a significant balanced practice in Hyderabad. We welcome you, Kiran. Thank you. And a third frontier for this debate is again a challenging virtue of this is Dr. Dheeraj Sonawne, who is working as a professor in JJ Hospital, the Grand Medical College, one of the premium institute in the country. And Dheeraj has got extensive experience of Indian implants, imported implants, as well as the hybrid implants. What is hybrid? That Dheeraj will tell us, because that's always we use mix and match. At times we use Indian sublamina wires, or we use some hooks and all these things. How he mixes and matches for patients of need, because he gets a lot of complex cases from all over the state. We welcome you, Dheeraj, for today's interesting debate number 2. And we have the last debate, the debate between Dr. Bhavuk Garg and Dr. Umesh Shrikanta. Dr. Bhavuk, I don't think he needs any introduction, as he is reached at epitome of great research and academics in India. He is working as a professor in All India Institute of Medical Sciences, and he is having extensive experience of minimally invasive surgery as well as maximal invasive surgery. And we'll see from Bhavuk what he has to say for fusion in infective spine. A lot of institutes have that ideology, fix it and forget it, debride it and fix it. Why you want to just do a procedure which will need one more procedure? And we welcome you, Bhavuk, for today's interesting webinar. And we have Umesh Shrikanta, the neurosurgeon from Bangalore, one of the most brilliant academician from Bangalore who was the secretary for MISAB, which was held recently, and he did a great show, spectacular event over the 3 weekends. We welcome you, Umesh, for today's webinar and the conflict between open versus MIS, decompression or debridement. And Umesh does a lot of minimal invasive work. He will be talking on debridement, lavage, and giving the spine a better, stable spine. So let's know from Umesh how he tackles this situation in infective spondylodiscitis. And at the last, we have someone who is definitely not confused, one of the great academician and researcher we have who trained in Ganga Hospital, and he's working with us as a colleague and very close confidant for us, Dr. Siddharth Iyer, a vibrant spine surgeon in Pune. He's working as a consultant in Sancheti Hospital. We welcome you, Siddharth, for today's webinar, and to hear from you about all the confusions, how you will demystify our confusion via research and the papers which were published. I welcome you all for this, and I will not take much time. Raghav sir is here, and I would like to hear from Raghav sir before we start our webinar. Raghav sir.
Lovely, Shailesh. I know more than anybody else, I should congratulate you for doing webinars and of very high standard. I participated in a few, and keep up the good work, because lack of conferencing, this is one way of sharing our ideas. And especially I'm so proud that so many youngsters are but has narrowed so much. Actually, of you guys are thinking. I'm talking about the Association of Spine Surgeons of India in general, and our association is in such a strong footing today. All corners of the country, compared to 94 when I came back, is gone up by leaps and bounds. And anywhere I travel in the world, which I do one hell of a lot, I see no difference. And in many situations, I find that the thinking of Indian surgeons, especially the ASSI members, is far better than the Westerners. So I'm very proud of you. But before we start, I just have a small request. I am, very sad and very upset with the death of Dr. Ramesh. He is one of our members. He died yesterday. I just request all of you, I don't know whether you know it or not, I was in touch with Bhavuk. He developed post-COVID complications. We know this guy for decades, very nice human being, a member of our fraternity. Just let's observe a few seconds silence in his memory. We lost last year, a year before, a very young man from Pune, and now this for us. Just a few seconds of silence, and I really pray for his Ramesh's soul to rest in peace. Thank you very much. So let's all stay safe as much as possible. Let's help our patients, but stay healthy, stay fit. Over to you, Shailesh. Let's start.
Thank you, Raghav sir, and heartfelt condolences to Dr. Ramesh and the family. We will proceed. Dr. Narayan Karne is here. Before we start, just a few words from Dr. Narayan Karne, who is the president of Pune Orthopedic Society, who is giving us great support, and he is a secretary of Maharashtra Orthopedic Association. Yes, Karne sir.
Good evening, friends. Very sorry for joining it late, because I was going to talk in another webinar which got little delayed. Well, I thank Dr. Shailesh Hadgaonkar, who is doing all the Spine Connect for last 4 sessions, and he has taken all the controversies from who's who in the field of spine surgery as well as from the neurosurgery, and the average orthopedic surgeons like us. I mean, we call it general orthopedic surgeon who do spine, arthroscopy, arthroplasty, everything to some extent. And we were a little bit relieved then that, okay, the Stalwarts also having some difficulties. So, but of course, we got so much knowledge, and the difficulties and the controversies which we see that adds more to our knowledge. And I thank him for choosing such a great topics which are useful in day-to-day practice also. Yeah, I thank the Pune Orthopedic Society for allowing us to do these things, and I thank Professor Dr. Ajit Shinde, who is the president of Orthopedic Association, to allow this to do under the use of MOA. And I wish success to all the faculties who are there from all over India, and I welcome them. Thank you.
Thank you, sir, for a great start. And we will head start with Dr. Ranjeet Unnikrishnan for the Confusion Man talk.
Can you see my slide? Shailesh?
Yes, Ranjeet.
Yes, sir.
Thank you very much, Dr. Shailesh. Thank you very much, Dr. Narayan Karne, Dr. Ajit Shinde, the Pune Orthopedic Society, as well as MOA. And Shailesh, thank you very much. I know I'm really amazed at the stellar faculty, the professor of AIMS, HOD of KEM. I feel too little and too difficult to sit here. Let me try and do justice to show my confusion, what I have in these cases when we face them. So for some reason, okay. So this is a 26-year-old female who had neck pain and minimal back pain, who noticed progressive difficulty in walking with no bowel bladder involvement, and she became paraplegic and was bedridden for 3 months when she came to us. And she noticed that she also had amenorrhea since the neck pain started. She was evaluated elsewhere, had a blood workup done, which was ESR of 34, CRP of 50. Nothing else was abnormal in the blood workup. The MRI of the spine was done, and a presumptive diagnosis of tuberculous polydiscitis was made. No histopathology was attempted, and she was started on HREZ since 3 months whenever she was bedridden. And this is how we kind of inherited the patient. And these were the X-rays on admission to us. I think it's fairly clear. You see a destruction here, a complete washout appearance. You can also see the bird's nest abscess in the thoracic spine. So most of us will agree that this is spondylodiscitis. We all might not call it tuberculosis. And this was the MRI on presentation. This was 3 months after ATT was started. This was the MRI. This was the CT. I will go ahead. Again, this was the axial CT and the axial MRI of the thoracic level, a D4. This was the D4 level. And this was again blown up pictures of the you can see that the entire spine is affected with all the vertebrae involved, with significant internal gibbous and kyphosis at the cervicothoracic as well as thoracolumbar level. And this is the axial section at the thoracolumbar level, the representative CT and the MRI picture showing the cold abscesses with a intraspinal involvement. And at this juncture, I would like to ask the young faculty, will keep Professor Shrivastava and Dr. Amol Rege's opinion to the last, because they're going to dwell into it further. So let me ask Dr. Rishi, what would be your solution for this problem, Dr. Rishi?
I presume you said she's paraplegic, isn't it?
Yes, 3 months, but bowel bladder is paired.
Right. So I will do a posterior surgery, probably from approximately that 2 levels above the upper thoracic level and 2 levels below the lower thoracic level. Again, and the thoracolumbar as well, posterior fixation, decompression, and aspirate an abscess, and then send it for the battery of investigations, which you usually send it for.
So you do a back and front, both upper dorsal as well as thoracolumbar, same sitting.
Same sitting, only back.
And what would you do for the front?
Nothing, we'll just stabilize and leave it.
So you would not refill the anterior column. You would just do the posterior column, because you can see that the entire vertebra is involved. So you're not bothered about any screw purchase.
No,
you would not be bothered about the implant failing because of the extensive involvement.
No, usually what I observed is the bone which is affected by tuberculosis, what we see as the area of osteolysis. The rest of the bone usually will be very sclerotic.
Okay, in this picture, don't you think that the multiple levels are osteolytic?
Yeah, even in the area which we pass through the pedicle and get purchased in the vertebral body, we usually don't face a problem.
Okay, thank you, Rishi. So you do both in the same setting?
Depends. I will start with the upper one. I think that's the culprit one which is causing the neurological deficit. If she's good to go ahead, then I will fix the lower one as well at the same time.
Let me ask Dr. Dheeraj.
Yeah.
What would be your solution for this problem, Dheeraj?
So I will agree with Rishi regarding the plan. I will like to go only posteriorly, since there is a good bone-to-bone contact and there is no void as such anteriorly. 2 level up and down should be fine. Regarding the hold, if I have a doubt, I will add sublaminar wire for extra encouragement. Yeah.
So you don't feel that the front void will open up if you try and go from the back and open this up? Don't you think so that this will open up?
No, I'm not worried about opening up.
Almost a total,
it will be fine.
if you see the CT, is a total body loss at both the levels. A total vertebral body loss at both levels.
Yeah, but this is less than 30-degree deformity, a very mild kind of deformity. I'm not worried about that.
Supine patient is supine paraplegic. So, probably when you make a stand, it might be more. Okay, let me ask Bhavuk. Bhavuk, what would be your solution for this problem?
So I agree with the approach that I will start posterior, but I will do anterior reconstruction as well from the back only.
Okay, you feel that the front has to be done?
Yeah, because we have published a comparative study as well, and we have seen that the only advantage from the posterior which we have is that we can adequately restore the kyphosis or the lordosis from the back. And the other thing is, like, she has already got 3 months of ATT, so probably we are looking at MDR, which could turn out to be XDR or TDR. So if I'm going in this thing, so I will do the thorough job in one go, and then then I will leave it to the conservative treatment, whatever we are going to opt for it.
Okay, so you'll do both levels same setting, right?
Yeah.
Okay. So for want of discussion, let me go ahead. So we'll have the stalwarts tell about which is better. I think more or less it's posterior with anterior reconstruction. And does anybody want to go primarily anterior in this?
No, I think we should keep it for the debate, because we will
So let me come to the problem. So I was I thought that the front column is definitely, when I open up in the back, the front defect is there significant. So I did what Dr. Bhavuk mentioned. I did both at the same sitting. I did the the upper thoracic as well as the thoracolumbar same sitting. I did a extended lateral approach, reconstructed the anterior column, and like what Dr. Rishi mentioned, I was expecting the screws to hold well, and it did get a good hold. So I went 2 levels above, 2 levels below, as at both the levels. Upper level took off a rib, this level reconstructed everything well. All looks good, and I used, of course, autogenous graft from the posterior iliac crest, filled up both the defects. Any critical comments at this juncture?
We'll take an opinion from Raghav sir, and then we'll proceed with the debate. Yes, Raghav sir.
Raghav sir. Raghav sir is logged in.
Raghav sir, you are on mute, sir. Raghav sir, you are on mute. You have to unmute.
I'll tell you when I go anterior, because basically I'm a big anterior surgeon when I started my career. Now things are a bit more posterior these days. But to answer this particular situation here, certainly this would not require the spine, thoracic spine. In the lower area, if you look at it, it's L5, L1, 2. And we know that in the lumbar spine, tuberculosis heals by subsidence. So I would just put graft from behind to reconstruct. I would instrument it. Obviously, there's no doubt about it, decompression. I would just put a graft like Ranjeet has done, but I wouldn't bother to do a cage, because if it is above L1, things are slightly different. Depending on the kyphosis, I may put a cage in the front. This particular case, only graft and posterior instrumentation. That would do.
Okay, sir. Thank you. Let me ask Shrivastava, sir, do you think this will succeed or this will fail?
Yeah,
It will succeed.
yeah. So first thing, I'm not fully sure whether you have taken culture of this patient. This is extremely important. To touch this patient before that, you should have sensitivity and culture. That is one thing. Second thing, these columns are extremely osteoporotic. And these cages, they usually try to sink inside the body, and maybe that is the cause of actually late failure of the implant. Okay, so in such situation, there where the column is pretty osteoporotic, I don't use cage. I use autologous bone graft, the strut graft you can use, and the result of that is extremely good. So these are the two concerns I have in this. One is the sensitivity of the bacilli. Whatever you do, it will fail if it is not a sensitive AKT. That is one. And second, osteoporosis. So we are having a race between osteoporosis and healing.
So you would do it in two stages. You would first get the tissue culture, and then you would go with the surgery, or you would go in one setting, sir?
No, pedicular biopsy. Pedicular biopsy will be done. You will be getting short material as well as the bone. You send for that, and you can take her for surgery in view of her neurological deficit.
Yes, sir.
And both the things can be managed from posterior approach very nicely without any doubt.
Yeah. So for my rationale was that she's already on ATT for 2.5 months. 3 months, she was dense paraplegic for 2 months. So I went ahead. I did exactly what you did. I took culture. I was expecting MDR TV because young male know the symptoms. I took culture, bacteriology, biopsy, everything, and did both the same setting. And interestingly, it came as tuberculosis. Regular, no MDR, no XDR, very much drug-sensitive tuberculosis. So primarily I reasoned that I thought that she's immunosuppressed or something. All her workup was negative, and the extensive involvement was a reason for her paraplegia and deformity. So as things would have it, she recovered promptly. By around 6 to 8 weeks, she developed kind of grade 3 power, and at 3 months, 4 months, she came in walking with a walker. And to start with, she had no ball bladder. She had no bladder post-operative also. And this is how she healed up very well, the upper thoracic part. And this is how the lower thoracic part started behaving. So this was at around 10 months post-op. At around 11 months post-op, she was walking, she had no pain. Slowly the upper rod, which I'm marking out here, was kind of jutting out and slowly giving pain there. She was still spastic, but walking well. And at this stage, 10 months post-op, she was independent walker. So which I initially, because of the porosis and all the catch, I had already warned them that we might have to go for secondary procedures if it fails. So at this point, I took dynamic X-rays, and I was thinking that it is kind of mobile. So as all would do it, I went ahead and got a CT done. And this is the CT. You can see the partial, bridging bone into the graft, across the graft, and the cage into the canal partly. And this is the axial section. This is the AP, and you can see that there is halo around the screw at the upper end. That means the bone is reconstructing, but the implant is slowly failing. So from here, the question is that, was my approach wrong? Number one. Number two, was my surgery inappropriate? Number three, did I do a technically incompetent surgery? Meaning, was my cage position wrong? Was my debridement not enough? Was my length of instrumentation inadequate? And now the question is how to solve it. So for that, we have two master blasters, two experts in their own situations, who would give a solution that was the surgery wrong, was the disease wrong, or was it executed wrongly? And I know, as all of us would do it, I went ahead and did a posterior revision. I went long, removed the screws, and I was expecting to do a revision VCA kind of situation if the cage come out And to my surprise, the cage was holding on very well. And you can see the X-ray after revision of 3 months. You can see that it was healing very well. And now she is still. Now I got a 1.5 years follow-up on her. Nearly she's off ATT. After imaging, nothing, no pus. It's only marrow conversion. And from that, I will open the floor to Professor Shrivastav and Dr. Rege. Thank you very much.
Ranjeet, can I just make a point?
Yes, Dr. Rege.
Yeah, I think very well managed case. But since most of the viewers are general orthopedic surgeons, I would like to stress that any of such patients surgically, you really need to evaluate them completely, especially for a biliary tuberculosis. So involving a chest physician, infectious disease consultant, and all workup is much more important before you think about surgery. And I would also agree with Dr. Srivastav that in such cases, maybe taking a biopsy before and starting, drugs and giving a trial of non-operative treatment is also important, is what my personal view is.
Yeah, in this case, she was already on 3 months of ATT, total paraplegic 3 months. And of course, we had an ID consult, chest workup was done, all those.
Yeah, I'm sure you've done this. I'm just re-stressing for the general orthopedic surgeons that workup is very important.
Yeah, point well noted, Amol, and I think very well done surgery, but it was always a confusion. And when the patient comes paraplegic, getting better, and again having implant failure, it's not very easy. It's a very dilemmatic situation. Did I do a short segment? I should have done all these things. So let's start with the debate. I invite Dr. Amol Rege to start the debate with anterior surgery for TB spine. Over to you, Amol.
Can you just play my talk, because I got a very internet here. So
yeah, I'm just playing it, sir. Is the screen visible?
Yeah.
Okay, I'm starting play.
Spine, role of anterior surgery in current era. Before starting my talk, I would like to make some humble submissions. Spinal TB is primarily treated medically. Biopsy with culture and histopathology is the only intervention needed in most patients. Secondly, surgery is primarily indicated if there is neurological complications. The other indications being non-responders, instability, pain, and deformity. Lastly, in my practice, if surgery is needed, the common approach is posterior. Though I'm talking on anterior surgery, I have to admit this. However, anterior surgery still has a role in selected cases, and I feel strongly that young surgeons should be conversant with anterior surgery. To support my first submission, this is a case of a 42-year-old male with thoracic pain of 9 months duration, a very bad looking MRI, but normal neurology. He had a biopsy which proved tuberculosis, and this is after 4 months of AKT. So just by seeing a bad MRI, don't jump to surgery. Regarding my second submission, this is a 58-year-old male on AKT with progressive paraparesis. So this is a case who has a clinical indication and a radiological indication for surgery. The disease is primarily anterior, and it appears to logic that the surgery should be anterior. As we know that the load bearing is the anterior column. 80% of the weight goes to the anterior column. And in the pathology, the TB of spine involves anterior column. So surgery should be anterior. Let us go back into history and see how anterior surgery evolved. So on the Wednesday lunch clinical meeting in 1953, Dr. Fang asked whether it's possible to do a thoracotomy. Professor Stock from surgical department said, I can get you to the spine. And Dr. Hodgson said that we'll debride and put a bone graft. So the Hodgson-Stock procedure became very popular, also called as the Hong Kong operation. And the first 100 cases were published in 1960. And this need of anterior surgery was mainly from the failure of posterior surgery. The instrumentation that time which was commonly used was either Harrington rod or Hartshill rectangle, and the anterior column was not addressed. And there were a lot of failures, pseudoarthrosis, and non-unions. So why anterior surgery? Because the pathology is anterior, decompression is reliable, cord handling is minimal, your graft will be under compression, you don't remove any posterior structures, so there is no destabilization. And unlike posterior surgery where you have to go multiple segments above and below, for anterior surgery, you don't have to do that. A few technical tips about anterior surgery. You should learn the applied anatomy, study your transverse sections of the CT and MRI. Careful positioning, either with the hip supports or a bean bag, is important. Usually the approach is from the left side. Incision is 2 ribs above the level of region. Protect the neurovascular bundle. So you open the thorax, reflect the lungs, and you're onto the parietal pleura on chest wall. You tie off the segmentals, identify the lesion, debride, decompress, and send everything for histopathology and culture. So this is a short video showing the steps. So the incision is taken along the rib. Then you cut the intercostal muscles and expose the rib. You strip the periosteum of the rib. I use a Cobb's elevator for that. The neurovascular bundle is on the inferior aspect. You need to be careful about protecting the neurovascular bundle. Isolate the rib, and with the rib shears, you cut the rib, which can be used as a graft later on. Then you pick up the parietal pleura, incise the pleura with the blade facing outwards, and you open the thoracic cavity. So you cut the parietal pleura, and the lung is exposed there. That is the aorta, and then you're on the parietal pleura chest wall, which you incise, tie off the segmentals. That is the diaphragm, that's the lungs, heart, and that is the lesion which is being exposed. For the thoracolumbar junction, it's a transdiaphragmatic approach. You expose the diaphragm from the thoracic side as well as the abdominal side, and incise the diaphragm circumferentially 1.5 centimeters from its origin, and you to repair this diaphragm at the end of the surgery. For lumbar region, it's a retroperitoneal approach. You reflect the peritoneum after cutting the abdominal muscles, and along with the peritoneum, you reflect the ureter. This medial border of psoas is your landmark. You have to protect the various vessels. Once you debride, you need to stabilize. Initially, only grafts were used, either the rib, iliac crest, or fibula, or allografts. But the problem with using only graft is there is a high incidence of subsidence, kyphosis, and dislodgement. And also there is graft site morbidity. Initially, it was thought that metals are not safe in tuberculosis. This article by Oga in '93 changed that concept, and soon people started using titanium cages, but using only cage, it will sink into the adjacent weak bone. So the ideal construct is to stabilize with a cage and a screw and rod construct with staples. So this is a case example of an anterior approach undergoing corpectomy, cage stabilization, and screw and rod construct. There are a lot of articles in the literature which support the anterior approach. There are two main issues with the anterior approach. One is that you can't correct the kyphosis, and the second major issue is morbidity. The problem of kyphosis has been addressed by doing a combined approach. So with the posterior surgery, you correct the kyphosis, and with the anterior surgery, you debride, decompress, and put in a cage. So there are a lot of articles by Lahiri, Dr. Moon, Dr. Sundarraj about this combined approach. So why did the anterior surgery fall out of favor? The main reason is the morbidity. The chest complications are huge. Here you can see a mottled lung. The vascular complications are also high. This is a large aorta on exposure. Patients need ICU stay, post-op pain is more, and the access at junctional levels is difficult. Biomechanically, as I said, it is difficult to address moderate to severe kyphosis, and in pediatric age group, you have to stabilize posteriorly. With the advent of posterior surgery getting modified and the concept of addressing the anterior column, and with techniques such as transpedicular decompression and shortening, the lateral extracavitary approach wherein you address the anterior column from behind, all this swung the pendulum from anterior to posterior surgery. So this is an article which compares the anterior versus the lateral extracavitary approach, and there was no statistical difference in blood loss, operative time, fusion rates, and functional outcome. For cervical spine, anterior surgery still remains the gold standard. You can do anterior plating, bone grafting. Very rarely you will need supplemental lateral mass fixation. For lumbar spine, again, you can't sacrifice nerve roots like in the thoracic region. And if the defect is significant, then you can't put a cage from behind that easily. So in such cases, again, anterior surgery has a role. So either you can go by retroperitoneal approach or at lumbosacral junction by transperitoneal approach. So this is a case example. Patient was referred to us after being operated and she had continuing pain, and there you can see anterior defect. The screws were loose. So we revised that and did an anterior transperitoneal approach and bone grafting for the lumbosacral defect. So the pendulum has swung from posterior initially to anterior surgery and combined surgery, and now what most commonly is done is a modified posterior surgery. The classical article by Dr. Bhojraj in 2001. So if there was an anterior disease, mainly the surgery advice for group A patients was anterior surgery. But if it was anterior disease with kyphosis, then a combined surgery. For group C, where the patients were not fit, had a posterior surgery with transpedicular decompression, and group D, where it was mainly posterior element involvement, it was just posterior laminectomy. I think things have changed with time, and this is a simplistic management protocol which can be followed. As you can see, the main surgery is posterior, but what is important is to address the anterior column either by shortening or by bone graft and cage stabilization. But in regions like cervical and lumbar spine, where you can't approach the anterior column from behind, anterior surgery still will be the gold standard. I salute my teachers, especially Dr. Bhavuk and Dr. Dheer, who taught me anterior surgery, and all the doyens, Professor Tuli, Professor Jain, Dr. Bhojraj, and Professor Rajsekharan, who have contributed immensely to our understanding of tuberculosis. I'm a very small man to debate against a great Professor Shrivastav, and I agree that posterior surgery has a major role in management of spinal tuberculosis. So finally, take-home message is review your indication for surgery. Anterior approach mainly for cervical spine, selected cases of lumbar spine. Anterior approach only for fit patients with anterior destruction and kyphosis in thoracic spine. If using anterior approach, achieve stability with cage and screw rod construct. For anterior or combined approach, counsel patients about morbidity and complications. Thank you.
Thank you, Amol, for the wonderful presentation. And we will request Professor Shrivastav, sir, to share his thoughts.
Yeah. Yeah, I'm going to share my slide now.
Yes, sir.
I don't know why my video is not starting.
Host has stopped video sharing of all participants. Request Supriya to please undo that feature.
Is my slide visible?
Yes, sir.
Yes, sir.
Yeah. A very good evening to all of you. I thank Maharashtra Orthopedic Association, Pune Orthopedic Association, and Sancheti Hospital, specifically Dr. Shailesh and Dr. Siddharth for giving me this opportunity to interact with all of you. Dilemma in spine surgery. Basically, today's topic is extremely important, and this is not a talk, this is a debate. TB spine surgery, whether one should consider anterior or posterior. Dr. Amol has very nicely given the lucid thought about surgical aspect of TB spine. It is very important that all the spine surgeons should know how to handle the spinal column anteriorly as well as posteriorly. But as the understanding in TB spine has evolved gradually, we have shifted from anterior to posterior, but still there are specific areas where anterior surgery is required. But most of the regions can be tackled very well by posterior surgery. Now, on the right side, you can see the deformity with a wet lesion, and on the left side, you can see there is a rigid spinal column deformity, which is post-tubercular. These two conditions cannot be handled from posterior aspect or from anterior aspect. So here the posterior surgery is extremely important, because from posterior side you can very nicely handle the column. You can maneuver it very nicely. Now, what should be the surgical approach in a case? And it should be actually decided by the indication of surgery. How is the feasibility in that particular case? What are the advantages of that particular approach, and what are the disadvantages of an approach? So these are extremely important. An operating surgeon must know the limitations of an approach. This is extremely important. Now, this is the cervical column right from occipito-cervical junction to lower down. Each component of indications of surgery in TB spine can be efficiently tackled from posterior approach, irrespective of the region of the spinal column. There is only one exception, and that is the subaxial spine. From C2, C3 to C7, T1, for anterior decompression and reconstruction, anterior approach is required, as vertebral arteries are placed laterally. However, excision of two bodies in 3 discs anteriorly in cervical spine mandates additional posterior stabilization. The posterior approach is extremely versatile. Dorsal spine and dorsal lumbar junction are commonly involved in TB spine, though the incision is in posterior midline area. But through this gateway, one can do anterior decompression and anterior reconstruction, and practically can venture circumferentially 360 degrees. And one can extend proximally from dorsal spine to occiput and distally from dorsal spine to sacrum. So this is a really very, very versatile, approach. Proponents of anterior approach usually claim that the TB is disease of anterior column, hence should be tackled from anterior side, and there is no need to disturb healthy posterior element. We do agree that it commonly involves anterior column, but a progressive pathology can involve the column's circumference. We very smartly divide the pathology of tuberculosis in paradiscal, central, anterior, and posterior. But this bacteria doesn't follow any classification. It can go anywhere. And we find cases where there is a circumferential involvement of the column and there is a significant cord compression. Now, in such situation, you have to decompress the cord circumferentially. It is extremely important for neural recovery. As a surgeon, we should not be approach bound. We should consider indication of surgery in a particular patient and how to approach to achieve the goal. The indications of surgery in TV spine, commonly it is neural compression with neurological deficit, where we wish to do the neural decompression, and void in the column after decompression should be reconstructed. If there is a instability, we wish to provide stability to the column by internal fixation. If there is an impending column failure, the patient might not be having a deficit, but this is bound to fail. It has been very nicely described by Professor Kiran by giving the spine at risk sign. So in such situation, we have to intervene early. And if there is a deformity, one has to correct it. Sometimes these patients they come with the late neurological deficit. And in such situation, this cannot be handled from anterior, and one has to do the posterior surgery. This is extremely important. So the deformity correction, mainly the rigid deformity where we require to do the vertebral column resection, it has to be done from behind. Just there is some message has come. Start video. I don't have any video. Neural compression with neurological deficit. Here, the compression is mainly anterior, which may be paradiscal or central. Sometimes it may be circumferential also. Now, after making a posterior midline incision, we walk laterally. And the area which I have marked with the red oval shadows. So if you have one lesion, you practically just disturb one side of facet and one side of the pedicle, and you can do nicely the anterior decompression from posterior route. Now remember, we are not going to excise the normal posterior element here. Even if you go anteriorly, you excise one of the pedicle, isn't it? You excise one of the pedicle, you trace the root, and then you take out the body. The same thing can be mirror image done from posterior side also. Moreover, if the lesion is extensive, you can do to other side also. You can, if there is a posterior compression, you can do posterior decompression also. Now, usually we will end up doing this. So there is a posterior compression. So the posterior decompression has been done. From this, you can see the root is visible, intervening root is visible, and the anterior decompression can be done very nicely, and it can be reconstructed nicely. Sometimes there is an eccentric collapse with early neurological deficit, mainly in the junctional area. Now, the junctional area, if you try to reach from the anterior side, sometimes your exposure becomes extensive. Sometimes you have to slit the diaphragm. Actually, these things are not required with this posterior surgery, and everything can be tackled from posterior side. Now, I just a case example, posterior midline approach. Here, everything can be done from behind. And that area where I have marked with the arrow, it is the gateway to anterior column. So you can go anteriorly from this area. You insert the pedicular screw for later on fixation, and you walk anteriorly, you decompress. Tricortical stud bone graft can be harvested from the iliac crest. If you have allograft, you can use and fix with the patient's cancellous bone, or you can use the fibula. So all these things are extremely important, and one should be aware about these biological facts. And then this can be inserted without causing much problem to any neural structure. Very gently it can be inserted, it can be packed, and see how it has been reconstructed nicely. You can put additional graft also, and you can bridge the posterior defect also. And this is the post-operative X-ray, and this patient recovered, and long-term follow-up was extremely good. This is the another case. Actually, he was a case who was, neurologically significantly deficit. He was bedridden, and the all component of problem of TB spine was here. There was translation, angulation, and there was a circumferential compression. He was extremely poor, and that's how we started thinking of using sublaminar wire and hard seal rectangle. And believe me, we used to do the whole surgery in 1,500 to 2,000 rupees. And that's how we started developing versatile approach. I will just show you. So in this case, everything can be done through this curvilinear approach. Here the patient is placed laterally. You take this incision. You can extend this incision proximally and distally as per your wish. There is no need of changing the position or taking two different incisions. To the same incision, you can go anterior, and that too transthoracic. A proper anterior surgery can be done you can do the proper decompression and reconstruction, and posteriorly you can come to the midline and you can stabilize the column very nicely. Here, this patient has circumferential compression, so the posterior laminectomy and taking out those compression material, those were the thick granulation tissue that could be taken out to the same incision. Now here it has been fixed. The deformity correction also could be done by sequential tightening of the sublunnar wire. You can have a very good correction with the sublunnar wire and Hartsin rectangle. And since these are not the rigid implant, they have micro movement, and it is extremely good for an osteoporotic spine. So thorough decompression has been done and reconstruction with the strut graft can be done. Now, this was the immediate post-op X-ray. You can see the nice alignment has been done. It was thoroughly decompressed and reconstructed, and this was the long-term follow-up. So through the single posterior incision, everything can be done. Posterior neural compression with neurological deficit, if patient comes with the deficit, he has posterior compression. And if you are going to exercise 2 laminae or more than 2 laminae, it is better to give stability. And here you can do the decompression and stabilization. If there is a instability or impending instability, providing stability is the aim, so the internal fixation is required. Now, if you see the spinal column, anteriorly it has compression surface and posteriorly it has a tensile surface. Biomechanically, implant should be put on tensile surface. With our orthopedic knowledge, we know that we must put implant on the tensile surface. In TB spine, because of infection and inflammation, bone is porotic, more so the body. So the chances of loosening of implant is high if you try to place it in the anterior column. Posterior elements are relatively better, the quality is better, and pedicle is the force nucleus. So you should take advantage of the intact posterior element. This is very crucial. Now, if suppose you have such situation where there is a AAD, now no anterior surgery is going to help and one has to do the posterior surgery. So the pediatric case, significant instability, and we had to go to the occiput and it has been stabilized and fused. Another case of CV junction TB, here the transarticular screw fixation has been done and fusion has been done, and this patient improved. C1, C2 cox with significant bony dissection. Almost the C1 was not there, it disappeared. You can see all bony small fragments are there. So here there was no way of putting any implant in C1 area. So we extended to the occiput and this patient recovered fully. TB of the lumbar spine can also be taken from posterior approach. Now, if you see this lesion, you can, as you do flip, similar way you can open it, even if the root comes, suppose you have 2 levels. So what is going to be in the intervening area? Root is going to be there, which you should not, and you should not try to manipulate the root. So what you can do, you can tilt the cage, pass in the space, and you can straighten it. Same you can do with the bone graft. Now, in this case, I have done the composite reconstruction. So I have taken care of the mobility of the lumbar spine, so no extra fixation, and this patient consolidated very nicely. In all these situations of deformity, I think anterior surgery is not going to work. So one has to consider posterior surgery. One should never attempt to correct through anterior approach. This is extremely important. Now, this is a case of severe rigid dorsal lumbar kyphosis. Posterior approach is the safe answer to this indication. The standard posterior approach, you take midline incision, go on the sides. Sometimes you have to take out the ribs, maybe bilateral, put your implant, have a temporary fixation, and then you can walk through anterior. You can see I have passed the catheter from one side to another side. So you are almost 360 degrees around the column. You can see this. So the deformity is still significantly visible. You can ligate the dorsal nerve root, you clear this, and then you reach anteriorly and you start the decompression. Now, laminectomy of all vertebrae involved in the internal gibbous has to be done. And then you have to do the controlled correction. Now here you can see these 2 columns are actually being united with the, just spinal cord. So you do the controlled anterior opening and posterior closing maneuver. And that's how it has been corrected, and make a bed of morcellized corticocancellous bone graft from the excised bone. Maintain the anterior column using mesh or expandable cage. Now, the anterior reconstruction is extremely important. What happens? We spend 6 hour time in fixation and we just throw the bone graft. So that is not going to survive. So anterior reconstruction has to be extremely meticulous. With the excised ribs, you can even bridge that posterior gap also, and it helps in union. And this was the post-op, and this patient healed very nicely. Good cosmetic correction of the deformity. So what are the advantages of posterior approach? It is cosmetically more acceptable, and you can approach the spinal column 360 degrees. The incision can be extended proximally and distally with each. It doesn't require exposure of vital vessels. So you are away from lung, liver, and major vessels, which you require to handle when you go anteriorly. Post-operatively, less chances of chest complication and other visceral complications. Since you are putting the implant on tensile surface, it is biomechanically much stronger, and correction maneuver can be done very easily. And as you have full control over the column, fixation can be extended proximally and distally. Suppose you find that one of the pedicle is broken while putting the implant, you can extend proximally or you can go distally. In small chest exposure, going anterior and posterior to part is the screw, you have to really distract the rib cage. Implant doesn't rest near the vital structures when you go from posterior, and it can be extended very easily if suppose there is a failure of the implant. Okay. What are the advantages which are additional to this? It doesn't require excision of any extra bony element. So as it is propagated by the anterior surgeon that you unnecessarily excise the posterior, no, it is not required. You are just going from one side, that you are taking out the facet and maybe pedicle of one side. You are going extra cavitary and you just take out the anterior things which is compressing over the cord. Okay, but the only limitation is when you have a lesion C2 to C3 to C7 to T1 lesion surgery. For anterior decompression and reconstruction, anterior surgery should be planned. There you cannot approach from the posterior side. So you should be aware about that. So the same reverse way if you go, so these are the disadvantage of anterior approach. It lies anteriorly and obliquely, so this incision is cosmetically poor. It is a limited approach, incision cannot be extended. It is near vital structure with all its problem. Post-operatively, there are chances of chest complication because the chest tube is going to be there. Anterior fixation lies on compression surface of the column, so biomechanically not sound, and there is a limitation of corrective maneuver in cases of deformity. In TB spine, because of infection and inflammation, bone is porotic and the hold of anterior implant is comparatively poor. Failed implant lies near the vital structure and revision is not as simple as posterior structure. So I'll conclude, posterior approach has all the features of versatility. Through this approach, one can decompress the neural structure circumferentially, can correct the mild to severe deformity very effectively, and reconstruct the column very meticulously to give a long-lasting, successful outcome. I thank you very much for your kind attention.
Thank you, sir, for extensive understanding and talk in this debate of anterior versus posterior. And as I was talking, this is not a debate, this is an understanding, and there are limitations to both the surgeries, and in very, very selective cases we need to consider anterior, and even anterior reconstruction is done from the posterior approach, as Dr. Rege was. I would like to hear from Dr. Raghav sir, the academic chair, his views.
I think now the most important person here is a young man, Unni. He said he's confused. I hope these talks are so lucid that no confusion is left. The problem is that surgeons are not being trained in anterior approaches. This is the fundamental problem, especially papers coming from Europe and North America. They are not trained to do anterior surgery. So they're trying to do everything posterior. It's extremely important for a surgeon or a youngster who wants to do spine surgery to be trained and be very versatile in anterior approaches. Now, why we don't do anterior approach is because it is tough, you need training. Posterior approach is easy, we're all familiar, and we know what the structures are in front, and there are not too many dangerous structures there other than the nervous structures and the neural elements. In cervical spine, except at the C1 area below C2, it's all anterior. Again, because you can't approach that easily from posterior side, so you do all anterior. In the lumbar spine, you don't need to go anterior because it's, as I said before, it all heals by subsidence. Now the problems come whenever surgeons say that I'm doing posterior approach. The minute you go in front of the pedicles, you're actually doing anterior surgery. It's the same thing. The anterior surgery is being done from posterior side. So I think if you leave away the that is present in some of these situations, severe kyphosis and the angular kyphosis, etc., where you don't have to correct the deformity, both anterior and posterior surgeries give equally good results. The problem comes with anterior instrumentation because most of it is kyphotic. That is the problem. So if you do anterior surgery, if your instrumentation causes more kyphosis, that would be a bigger problem. So you should be experienced to do from anterior side. You should have good apprenticeship to do these procedures, do it yourself. And then if you can avoid certain situations as these deformity corrections, anterior approach gives as good a result as posterior approach. But it's always good now to go posterior because it's easy, familiar in the thoracic area and do the job in the front very nicely. Implants fail because of the nature of the bone. You need to be careful. What I wouldn't advise is cages, expandable cages, because they are more prone to failure. I wouldn't use them in tuberculosis, maybe in tumor situations you use them. But either way, tuberculosis is such an easy disease that you can get away with good result where you go from front or back. So in conclusion, cervical, anterior, below C2, rest all posterior. And if you are not well versed with anterior approach, go from behind and tackle the anterior disease. Most times, it's easy to get away with bone grafting. That's my view. We can take some questions if people have any doubts in this.
Yes, thank you, Raghav sir, for this wonderful explanation. I just would like to ask Amol only one question after hearing both. One indication where you will consider anterior surgery in TB spine, Amol. I think, yeah. Dr. Rege? I think there is some network lag. I would like to ask same question to Dr. Shrivastav. Yeah. So you have one indication to consider only posterior.
Only posterior craniovertebral area.
Okay.
And because I can nicely handle anterior also from behind. The C1, C2 joint is laterally placed.
Okay.
You can very nicely handle. And if the C1 is destroyed, you can extend to occiput.
Okay. Okay. I think it's a wonderful discussion.
Shailesh, I want to ask one question to SK, sir. Yeah.
Yes.
Yeah. So, good evening, sir. So my question is, for 3 level or more anterior involvement with minimal deformities in spinal TB, in that cases, we have to go posteriorly and do extensive debridement. And after debridement, the size of the cage of anterior reconstruction is so big that we are always worried about the construction quality. Even after shortening of this column, the cage size won't be that changed. Yeah. So how you manage these cases, sir, please?
See, in dorsal spine, there is no problem at all. You can ligate one of the nerve root and you can go anteriorly without any problem. In lumbar spine, you have to tilt your graft or cage and try to pass between 2 roots and just go anteriorly and try to correct that angulation from the distal area. So you try to imagine the 2 roots are coming out. Okay. So either from proximal or distal area, you try to insert the cage or graft horizontally, tilt it inside the canal, pull it from the proximal side and make it straight. And you compress the column little bit. Okay. So basically, this is a trick of inserting the thing, which has to be followed in lumbar spine. Otherwise, dorsal spine, one of the root or two roots also you can ligate. There is no issue at all.
Okay.
Can I just add something? You know, some of these situations where you're describing, most times you don't need cages.
Yeah.
Most times in TB, it's such a benign disease.
Yeah.
Yes.
And
yes.
we are confusing this with some early onset scoliosis or something like that. Now, if you have to use a cage, right? Why don't we do a combined procedure? It takes just a couple of hours to open up the chest, put a nice debridement, put the cage, turn the patient depending on the situation of the bone, do posteriorly, fix the spine, go front, debride it, put a cage. It's not a big deal. For example, I do this especially in the cervicothoracic junction, where there's a C7-T1 area. You can easily approach from the front. I do a thorough debridement, put a graft or a instrumentation from front, turn the patient over and correct from behind. So we must not be shy of doing combined procedures. It is much safer, much easier. You do that, go have a coffee, come back, turn the patient and do the surgery. Why suffer so much? Why sacrifice the nerve roots? I won't do that. So I would do a combined procedure, much, much easier.
Perfect.
The only problem perhaps is at L5-S1 junction. That's a slightly dangerous area to approach.
So I think the message is very, very clear. In spine, it's not only one spine. We have to consider cervical spine, thoracic, and lumbar spine. There are 3 different territories, and we have to select the patient well for doing the surgery. And there are some indications for anterior surgery even today. And as everyone was talking, because of various traditions and institutional protocols, people are preferring more safer surgery and posterior surgery, but there is a role for anterior surgery and reconstruction. Yes, Professor.
Can I make a comment here?
Yeah.
Actually, when you are planning to use a cage, which is slightly longer inside, it is advisable to ask the company to give the ring at the end of the cage. Okay. So if you have ring at the end of the cage, proximal and distal, the chances of sinking of the cage in that bone is less. And I think at many places people have started using this, because these sharp edges, they practically sink, and in post-op you will find that your cage is lying just overlapping the screw in the center. So I think this is important, that biology is to be addressed properly. Prefer to have bone graft. More graft is more forgiving than the cage.
Perfect. Well said, sir. And there is some issue with Amol's internet, I think. And we will proceed with the next confusion from Dr. Ranjeet Unnikrishnan about implants. Which one we should consider, Indian, imported, or hybrid? Yes, Ranjeet. We'll take all the questions at the end of the session, as we need to consider time as well.
Can you see my screen?
Yes.
Shailesh? Okay.
Yes.
So let me go to for want of time, we'll go quick on this. So I know this is a dilemma which comes to the mind of most of us when we decide on a situation where we need an implant. What do we do? Do we go with imported or do we go with Indian? For some reason, my slides don't seem to. Okay, fine. So I kind of we have Dr. Kiran, who's got a lot of international patients. So this is one of those international patients whom I inherited. He was a 63-year-old male who had back pain, leg pain, kind of stenosis, had a surgery done in the back, and I saw him after 4 years of the index surgery. So he had back pain, leg pain, was diagnosed to have tandem stenosis. I presume I had no details other than the X-ray when I saw him. He came back with significant back pain and again difficulty in walking. So this was the X-ray which we took then, and we could see that he had broken pedicle screws at the upper level. And I was not very sure that was the reason for he worsening. So this were his cervical X-rays. He had a single level ACDF done with a adjacent segment disease. Prolapse at the higher level, and the cause is quite obvious. We can see that the plate is almost jutting into the near the end plate. And then we was thinking that, did the implant fail because of the so-called not respecting the sagittal balance? So we got a whole spine X-ray done, and the C7 plumb line was not really offline. So it was not a really imbalanced spine, which led to this breakage of the implant. And these were his CT of the lumbar spine, which showed that there was halo around almost all the screws. And I was suspecting that something was attempted interbody at these levels. And this was the MRI at the L3-4 level, which showed significant stenosis with almost all the posterior elements intact. So I feel no decompression was done initially there. And this was his MRI. MRI of the cervical and lumbar spine, which showed significant stenosis at L3-4 with also adjacent segment disease at the cervical spine. So more or less the treatment is quite straightforward. So what really went wrong? Was it the implant? Was it the surgery? Or was it the choice of implants? I don't know. So as we all do it, I went ahead, did a revision, removed the broken implant, did interbody at the respective levels and went to a S1, did interbody at S1, and also extended higher up, did interbody there, and he was fine. This was an open surgery. And I also did his cervical spine from the back, and he promptly recovered. Now, so was it that this was an imported implant which was used in this case? So I was thinking, okay, the only imported implant definitely fails. So what about the Indian implant? This is my own patient. It was an L5S1 back pain, leg pain, manual laborer, had some kind of discal procedure done years ago, had significant back pain and leg pain, more of back pain. He was a manual laborer. He was like, I tried all sorts of non-surgical therapy. He was saying that he is not able to go back to work because of back pain. He was a fisherman. So at this point, since I sat on him for almost 1.5 years and he was not getting well, so I told that we can try surgery with guarded prognosis. So since it's back pain, those days, this is in the early 2012s, when we did a MIS TILIF, I used an Indian implant for this. This was an MIS TILIF done with an Indian implant. Surgery went off very uneventfully. There was no issues. Patient had very good back and leg pain, back pain relief, and he had minimal leg pain, which also was better. So he went back to his profession, was fine, and he came. This was after 1 year. 1 year routine follow-up, no symptoms. I took an X-ray, and I could see that the screws had broken. Screws had broken, and also I felt that the cage had, if you go back and look at my previous immediate post-op X-ray, my cage was centralized in AP and lateral. And if you see my 1 year post-op X-ray, that it was, it had moved. So I don't know when it moved because this is 1 year follow-up. So I told him that this is the situation, this is broken. Since he has no symptoms, let us sit on it. And if he develops symptoms, we will try and see what is to be done. So this was his follow-up. This is after 1 year of the broken screw. This was in this is 2012. This is 2013. This was 16, and this was 19. So 19 was the last follow. He told me he has no symptoms. I told him that let us wait on it. And since he had no symptoms, I thought that we'll get a CT or something done for academic interest. He told that, doctor, I have no symptoms. What will you do by doing a CT? I told him nothing. I'll just know that it is healed. He told, I have no symptoms now. So why should you want a CT right now? Since it was kind of informed decision, we just sat on it. And I have follow-up on him as late as 2020, just before the corona started. And he is fine. Now, what went wrong? Was it my surgery in the second case, or was it the surgical decision in the first case? Was it the decision in the first case? What is the kind of surgery? Was it a technically incompetent surgery? Or is it the implant? Or is it the debate between imported versus Indian? With this, we will have three stalwarts, Professor Sonavane, Dr. Kiran Lingutla, and Dr. Rishi. And let us get their wisdom and see what is the outcome. Thank you very much.
Thank you, Ranjeet, for a wonderful confusion. And we really are puzzled now. We don't know. And this is one of the hottest debate in the country today. I would like to request Rishi to open up the debate. Yes, Rishi.
Right. Thank you. And I thank the Pune team for having invited me and bringing this wonderful topic to discussion. I think this is one of the few conferences where such a topic would be discussed, I think. And I think this topic also holds more importance as we are doing more and more instrumentation surgeries. What the United States witnessed about 20 years ago, we are witnessing now as more and more young surgeons are taking up spine surgery, and the number of instrumentations have increased tremendously. So we have a plethora of spinal implants available in our armamentarium. So we use this pedicle screws, rods, cages, different types of cages available, the interbody, the mesh cage, expandable cages, the anterior cervical plates, and recently the minimally invasive system, and some specific instrumentation like the occipitocervical fixation, and several sundries like the transverse connectors, rod-to-rod connectors, and wooden-tied screws. But by and large, 70 to 80% of any spine surgeon's practice would involve these four stuff: the screws, rods, cages, and the anterior cervical plates. So whenever there is the dilemma for the spine surgeon to choose between selecting an Indian-made implant and an imported implant, what are the things that he needs to take into consideration? I think this is more of a philosophical thing, and it has less of a scientific backing, but I could able to pull up an article to support my contention. So generally, how do we decide? So we decide what type of material has been used to make these spinal implants. What about the durability of the implants? Are these implants really durable? So at the end of 1 year of follow-up, would these implants break? And second would be the cost of the implants and how cheap or how expensive would it be? Third would be how easily available and accessible are these implants for the surgeons to use? And finally would be the ease of using these implants. So more than the implants, sometimes the instrumentation has a bigger role to play in selecting these screws. So coming to the first one about the material and the durability. So almost all the screws, whether they are made in India or in the Western countries, they are all titanium alloys. And these are pretty much standardized. Whatever the implants available from for Indian practice, these implants have standardized licenses received from both Indian as well as international agencies. This I took from a very popular Indian implant company. So they have these standard licenses. The first one is the MD license, which is a medical drug license approved by the Drug Control General of India, which would be a central licensing authority. And so what they have given is they have a standard set of rules which have been amended as recently as in 2017, where all the medical devices have been classified from A to D based on the low to the highest risk possible. And orthopedic implants will be classified under class C or D device. So usually A and B devices, they need only approval only from the state licensing authority, whereas the C and D devices need a central licensing authority, and only after they go through rigorous processes, then only these implants are approved by the central licensing authority. Second one is the International Organization of Standardization, which is ISO certificate 13485, which again is received only if the quality management system has been shown to have implemented all the appropriate measures, and safety and efficacy of these devices have been proved in vitro measures. Final would be the CE certification, which is a conformity with the European Health. C and E stands for conformity with the European Health and Safety Standards, which enables these implants even to be used in the European economy area. And they have a set of American standardized testing measure standards for different type of implants. There are different ways how they check the biomechanical strength of these implants. And some of these implants, they have to be checked for durability to almost up to 50,000 cycles to show that the implants are able to withstand the daily stresses. As we all know, all these implants work well till the spine fuses. So they are not meant to be working lifelong. So at least we expect the spine to fuse within 1 or 2 years. And if the spine doesn't fuse, the implant cannot bear the stress for a longer time, and it is likely to fail, whether it is a Indian made one or an imported one. The second and the third decisions factors which we need to take into consideration before choosing an implant would be the cost and the availability. And I think this is the more important argument to choose an Indian implant. So it tremendously cuts down the cost. So the cost of the entire surgery drops down by at least 50 to 60%. So a fusion, a single level fusion of the lumbar spine can be done at half the price compared to when we use a Western made implant. So it naturally gives benefits to everyone. It gives benefits to the hospital, the institute where you're working. It gives a bigger profit margin for the surgeon, and it also cuts down the cost for the patient as well. And in some situations, it also gives you the freedom to use more screws. For example, if you are using a deformity and you are constrained with the cost for the patient, you are worried about using adding one more screw at which you think would be beneficial for the patient. You have to explain to the patient if you are using an imported screw, because the cost is going to increase by another 15 to 30,000 rupees. Whereas, and if you are using an Indian screw, you don't need to worry about it. The fourth one is it is very useful in early revisions. For example, if there is a spinal infection after a spinal fusion, where you think that you need to remove the rod, remove the screws, it's easy to change these screws with another 10 to 12,000 added cost. Whereas if you are using if you are used a imported screw in the index surgery, then if you have to change all the 4 screws, then the patient loses another lakh rupee more. And if you are able to use an Indian screw and able to operate a patient at a much lesser cost, then you'll be able to cater to a larger section of the society. So you don't restrict your practice to one niche group of patients who are the real affordable, belonging to the creamy layer of a society. And your ability to cater to a larger section of the our society, which is usually the 60% of our population. So if you are able to do more surgeries for such people, your quantity increase, your experience, you're able to reduce your complications, which will be more beneficial to a patient as well. And the more Indian screws you use, the more you are going to support our economy rather than boosting the economy of a Western country. And there are some flimsy arguments against the use of Indian screws. Some would argue about the quality of the implant. So some of the X-rays in the shown in the first case by Dr. Ranjeet, you would agree that it is more the type of surgery and the extent at which the fusion has been attempted that should be blamed rather than the quality of the screws. But for the record, if you ask about the quality of the screws, all the Indian companies, they have all the boxes ticked. And second argument would be that it would be difficult to do surgery in a complex situation. For example, a deformity or a high-grade listhesis, where you definitely need an imported screw to have very good results. There is also a flimsy argument. So this is an example where there's a very poor girl, 14-year-old adolescent with a high-grade spondylolisthesis, almost a grade 4 spondylolisthesis with back pain and bilateral radiculopathy. So she was treated with an Indian implant, and this was the 1-year follow-up picture, which shows that we can use Indian implants and give good radiological outcomes as well. Again, another child with the scoliosis, about a 60 degree double major curve, and operated with an Indian implant with good outcomes from T3 to L4. So there are obviously some disadvantages where there are situations where you would consider using an imported screw. So if the deformity is like more than 90 to 100 degrees, where you can't rely only on the extent of your bony and soft tissue release, where you need to have stronger screws and stronger inventory to have a better reduction of the deformity, then obviously you need to use Indian imported screws. Second thing would be the inventory issues. So some of the Indian companies make these odontoid screws, but I find the instrumentation to be cumbersome, and naturally we are forced to use an imported one for an odontoid screw fracture fixation. Sometimes I see anatomical incongruities between the type of cages that they have made with the natural anatomy of the patient. But if you have done a good job in terms of preparing the end plate and having a nice fit, even though the X-ray may not look a very cosmetic one, but the functional outcomes would be good. And again, sometimes they lack the finies. 1 in 100 times you may see that the nut doesn't fit very well into the screw head. Then you may need to change the nut, or you may need to change the screw at that particular moment. But that is, as I told, it's a 1 in 100 moment. And finally, it doesn't give a rich feel to the surgeon as well as to the patient. So the surgeon himself feels that I have met a few surgeons who categorically say we don't use low quality Indian implants, we use only the imported ones when they discuss a surgery to the patient. The patient also subjectively feels that when we use an imported one, they feel that they have something better inside their body compared to a Indian made screw. Again, as we discussed earlier, it's the quality of surgery that matters rather than the type of implant that we use. And like I said, there is one scientific evidence from our own Dr. Rabain and his team. It's a wonderful study. They have studied 239 patients, 1,500 screws used, almost equal number of Indian and imported screws, and they found that there were no higher incidence of implant failure compared between the Indian and the imported screws. So in conclusion, the second argument which I had put in front, the cost and the easy availability of the screws has to be taken into consideration, because 60% our population is living below the poverty line, and everybody has a spine, and everybody can get a spinal problem at any point of time. And cost should not be a prohibitive factor for them to have the benefit of a spine surgery. And we very well know that only less than 20% of our population have a private health insurance coverage to afford the high cost surgeries. And if as an Indian, if one can do something to make the life of our fellow citizens much better, is to be Indian and use Indian rather than using only imported screws for all the situations. Of course, like we discussed, there are like a 5% situations where you may need to be forced to use an imported one, but rest 90% of the time, an Indian implant very well supports our surgeries. Thank you. Thank you very much.
Well said, Rishi. We'll have the debate after the 3 presentations. And next speaker, Dr. Kiran Lingutla. Over to you, Kiran.
Hello, good evening. Yeah. Is my screen on, I hope?
Yes, Kiran.
Yeah. So very good evening to distinguished seniors, faculty, and my dear colleagues, and also to Pune team for having me for this talk. So my talk today is about imported implants that we use in spine surgery. I had an opportunity to train in England, so most of the spine training has been done there, and I've been here since the last 5 to 6 years now. So we have broken down this talk into various forms like economics, basics of the materials used, the basic science, R&D, what is an FDA approval process, the training, and the niche product portfolio, and finally the innovation and the newer technology as well. So coming to the spine implant market, by 2027, it is expected to reach somewhere about $15 billion, the spine implant market. So the elephant in the room is the cost. So let's talk why the cost is so high for an imported implant. Coming to the basic science, so spine materials that are most commonly used in manufacturing spinal implant, in an imported one, that is titanium, which is grade 23, which is a titanium, aluminum, and vanadium alloy. But in place of vanadium, now they are using niobium, because vanadium has cytotoxic properties when it is isolated, when there is a failure of the implant. So that's why this titanium grade 23 is used in most of the imported implants, whereas our Indian implants are grade 5 titanium. Other implants are cobalt chrome, biologics. PEEK is another material that is quite commonly used. Ceramics, tantalum is a trabecular metal, and biodegradable implants, that is making use of polylactic acid. So coming to the basic science, in the stress strain curves, we have different materials behaving different properties on the stress strain curve. So if you look at the titanium, which is number 4 on the graph, it is quite a ductile material, and your peak falls between your cortical bone, which has about 1 gigapascals, compared to titanium, which is about 4 gigapascals, when compared to rest of the biomaterials. So product R&D, these spinal implants are tested according to several ASTM standards, which is American Society of Testing and Materials. The FDA, the Food and Drug Administration in the US, often recommends these standards for considering of new implant designs. So when you have interbody fusion devices, the test methods is F2077. For spinal artificial discs is 2346, and F1717 is the most common test used for spinal constructs, the posterior spinal constructs. There are different tests in each methods, like they do 3 static and 1 fatigue material test for a spinal construct to pass the tests as well. So what is the US FDA approval process? Why it makes it more expensive for the implant once it comes out? FDA is an organization which is responsible for protection and promotion of public health by regulating marketing devices so that the patient safety is maintained, and it gives assurance of safety and effectiveness when the product is eventually marketed. So these medical devices are usually categorized into 3 classes. One is a class 1 device, which is the lowest risk, which obviously has the least regulatory control. Class 2 device is a high risk device, which require stricter regulatory controls. And class 3, which is the highest, which causes significant risk, which poses significant risk or injury or illness to the patient. That's why it has the highest level of regulatory control. So nearly all spinal implants fall under class 2 and class 3 category in the US FDA portfolio. What is a class 2 device? Class 2 device typically requires a 510K clearance. This is the most common pathway for most common market entry products into the spinal industry. Whereas a class 3 device requires a pre-market approval, that is the PMA. It's more extensive, complicated. The main difference is where we have to submit clinical data to get clearance in a class 3 device. In a class 2 device, you do not need to submit any clinical data. So what about training? See, most of these imported implants companies have medical education and product training courses, which are usually offered to trainees and even after following into the consultant jobs as well. It ends usually on one-to-one training. It is surgical instruction, case observation, hands-on cadaveric learning as well to increase confidence levels. Group learning as well to share between surgeons, which has a low surgeon to faculty ratio, topic-based didactic breakouts, and cadaveric exercises as well. And they also give an opportunity to do some lab and clinical research opportunities. And also, if you have any failures of any implants, they can be explanted and send them back to the factories where they can come back with a solution and also give you a customized instrumentation for the surgeon as well. So these are the usual uses for these companies provide. So why do implants fail? Because there is usually a race between fusion and failure. Why does the implant fail? There are factors like patient factors. One is obesity, and the two is smoking and non-compliance of the patient. And implant factors are material stress failure. There is usually an interface failure either in the tulip or the rod, or in the tulip and the screw itself. That's where the implant fails. And biocompatibility as well. If you use two different material implants, you have failures. And in patient factors, you have osteoporosis as one of the common factors for failure as well. And there are surgeon factors which need to be looked into, that are suboptimal fusion techniques, malposition of hardware, and patient selection, which is very important. And also, how do you plan to use your implant? Is it a load bearing or a load sharing construct? So coming back to the paper, which is very nicely analyzed by Dr. Abhinay sir and his team, which shows absolutely minimal breakage or rod breakage or screw breakage in the foreign implants group. But however, statistically, there is no difference between the Indian and the foreign implants in their study. So what does the product portfolio offer? When the product portfolio of an imported company, they are usually offering you segmentation by products like spinal fusion implants, biologic vertebral compression fractures, treatment devices, non-fusion implants, spine growth, electrical stimulation devices as well. And they are segmented into end users like the hospitals, spines, dedicated spine centers, or market segmentation by surgery opener, MIS surgeries as well. So some of the niche product portfolios which are lacking in the Indian portfolios probably is cervical disc arthroplasty. This is one of my patients who has undergone a cervical disc replacement, which is lacking in the Indian portfolio. So we are forced to use these foreign implants as well. And something like a sacroiliac joint fusion. This is during my training in Wales. This is one of the patient having the SI joint fusion procedure done. This kind of niche product, when you want to use them in Indian scenario, they would be lacking in the portfolio. What about innovation and newer technology? There are various what's like 3D printed interbody devices, which promote significant more bone ingrowth 6 weeks post-op compared to peak and solid titanium implants. And there is also emergence of navigation and robotics, which the foreign instrumentation and the foreign screws offer with these platforms. I had a chance to actually give this talk, and also I had during my training in Cardiff, we published this chapter on spine implants, which was published in Springer, Radiology of Orthopedic Implants, which quite extensively deals with all the implants starting from cervical, thoracic, and lumbar to sacral as well. Thank you.
Great, Kiran. It was a very nicely made talk, and with no offense to Indian implant, because this is a challenging thing, given it comes to Indian versus imported. Very, very well done talk, and we will be happy to see our next speaker, Dr. Dheeraj Sonawane, for the hybrid implants, and then we will have question answer and the debate will continue. Over to you, Dheeraj.
Okay. So my talk is on hybrid implants, and I did not say anything on this because most of us here are using hybrid thing. So whenever possible, we are taking advantage of the Indian, and whenever possible, we are taking advantage of the imported one. A slide is not moving here. So what are the factors which decide whether you have to use imported, whether you have to use Indian implant? The most important we all know is the cost. But apart from that, there is a surgeon preference, indication for the surgery, what kind of setup you are. Is it a government setup with a particular scheme and funds allotted for a particular surgery, and a corporate with no issue at all with regarding the cost? Regarding the what kind of instrumentation set is available with a particular company, as Rishi rightly pointed out, for Rheumatoid, he has some technical issues for insertion. I also have some issues regarding transarticular screw or some deformity surgeries where the set of the instrumentation is not that good. Regarding revision of the particular implant, there are some advantages we will discuss on that. Supporting service like neuromonitoring, a revision instrument set, which are available with more in the imported one. Company assistance with a trained manpower and trained assistant, which we work in routinely. Patient demand and academic support. So what are the merits? Yes, we all know the cost is the biggest merit of the Indian implant. They are almost 5 times less costlier as compared to imported, especially in pedicle screws. Also, we must not forget regarding the availability and the reach of this Indian implant. Even in the peripheral and rural hospitals, these pedicle screws are made available, and which is difficult for the imported implant to reach. It has been tried and tested since decades, and they have given excellent results. They are innovating with Indian surgeons. One of our panelists, Dr. Ranjeet, has given this design for a MIS screw for an Indian company, and that has given a fantastic result since decades. So the services, apart from the academic services, they also they are always in close contact in our busy practice. They help us as assistants for our day-to-day non-professional work too. So this is the biggest advantage of all this Indian company, and majority of surgeries are Indian. But one shouldn't forget the biggest disadvantage are these all are copied implants. Okay, we have not done our R&D and not innovated, most of us. There is discrepancy regarding the implant. As Rishi rightly pointed, it is not anatomical in most of the cases, but though we have managed somehow. Also, the instrumentation set is not going with the implant. Most of these Indian implant companies do manufacture the implant at their own setup, but the instrumentation set is imported from China. So where the problem arises, especially in taps, but the screw threads and the instrumentation tap doesn't match exactly. Also, though, when we inserted a ACDF cage or PLEAF cage, you can see sometimes there must be some discrepancy regarding the size of the implant and the size of the sizer which is provided with the instrumentation set. So all these issues happen. There is no biomechanical research studies with Indian implant, though there was a clinical study, which is only one study by Dr. Abhay Nede. The raw material is the issue I will discuss in future slide where the issue arises. And hence the implant slightly complication, and we are not happy with the fineness. So we will discuss one by one regarding a few common implants. So Indian implants, all my routine cases, which is traumatic, infective, degenerative, I love to use Indian implant, except for severe rigid deformities. So why? What happens? So there are a few bad experiences. There are screw broken at the runout. There is tulip. The tulip has got disengaged with the threaded part of the screws. And when you try to reduce this deformity, and I prefer to use the cobalt chromium rods. And while placing this cobalt chromium rod, especially in Indian titanium screws, there is it cannot fit the aegis, especially in while pushing with the cantilever technique. So you can see, while in such cases the engaging ini is difficult. Even after changing the screw or changing ini, it doesn't help. And the kind of devices, the reduction devices is not that great, especially for the deformities. Other Indian implants like hook, they are freely available. We always like to keep in our set for difficult pedicle screws for extra encourage. But the implants and instrument are not that fine, and it's not that easy to insert as compared to imported. The design is not that sleek. However, against the imported, it is very sleek. One of my favorite Indian implant is a sublaminar wire, and we are using sublaminar wire from C1 to the sacrum region for all the kind of surgery, and it has been a bailout for osteoporotic fracture. and also in extensive infection, the secondary infection where there is a screw loosening. Also in tuberculosis, it provides an extra anchorage and the posterior elements are intact. So it's a fantastic implant, sublaminar wire, but it has a drawback, which is MRI compatibility. It might create a artifact which might interfere with the spinal cord. When you want to see a spinal cord, in that case, a Mercian tip has some advantages there. Pediatric pedicle screws. Pediatric pedicle screws is definitely a very good implant, but the Indian implant of pedicle screw, the tulip is as big as the Indian pedicle screws for an adult. So in that case, whenever possible, I try to use a low profile adult screw, which is slightly lesser size of a pediatric screw. It has two advantages which I have seen. The size of the rod is bigger, hence I can provide, especially in deformity, I can use a stronger, my construct will be more stronger. Also the threaded part, which is limited to 4.5 and maximum 5. Sometimes I have to use a bigger screw. Then there is no issue regarding the diameter of the screw. So yeah, this is anterior cervical plate or any cervical spine surgery. There is only a 2 times cost difference between the average Indian implant and the imported plate. And in some cases, I will love to incline towards the imported one for only anterior cervical. But if I have to do a both surgery, anterior plus posterior, then I have to use a mix and match, a hybrid thing. So especially for the posterior reconstruction, where the cost difference is more than 5 times. My bad experience regarding one's anterior cervical plate, which I used to use commonly in a special scenario when I was angulating the screw slightly more caudally than it is required in routine. It was a young patient with a good bony pulsion, and while tightening, it has just crossed the plate. And just because I was alert on table, I have disaster on table was avoided. So these implant, though design and copy very good, the raw material and the exact design won't be reached up to the imported one. So these are the spinal deformities. I love to use a cobalt chromium rod and put to a straight coronal, get a coronal maximum correction. So these if I try to use this with the Indian implant, it won't accept the titanium screw, don't accept the cobalt chromium rod. It tries to open up. So I prefer to use, especially in deformity, on the stress side, wherever I have to place first rod, that side I prefer to use a imported one, and a mix and match of Indian and imported on the other side. The other advantage is the persuader, the correcting devices, the benders are fantastic with the imported one. Also, the screw profile is low. There are some other advantages where I have to put such a long screw with 20 around screws. They provide a drill system which will save a few minutes for every screw insertion, and which is attached to neuromonitoring connection, which also adds a few more minutes and save an hour or plus at the end of the surgery. So there is another, so Indian anterior cervical cage with screw system. So this is a fantastic copied design by us, and it is having relatively no issue. However, sometimes there is some play between the screw and the cages, and the graft size area is variable from various Indian company, and the play in the screw and the cage give rise to sometimes the screw might not be inserted within the body. It might push the body if it is not sharp, and also the size of the cage and the size there is some discrepancy in with most. For C1, C2, my favorite for Goel Harms or occipital cervical is mostly Indian company. But if I have I have to go for a transarticular screw or a odontoid screw, as Rishi rightly pointed, the instrumentation set is slightly better. Hence, I am more inclined to for the imported. But however, Indian companies are matching. After surgery care, as we all must be knowing that every screw there is a lot number and there is a batch number for the implant. The revision set is available even after decoding imported one. The difficult implant removal set, even a broken screw removal set is available with the imported one. And they keep stickers and in their record. The post sales in case of medical legal issues will be tackled by the imported better. So when I prefer an imported one, when there is a crucial or challenging surgery, there is no cost issue at all. When the patient is close, I don't want to take any chance in that cases, and when there is high forces in case of high grade distress, then deformity. So when I prefer, most of my work in public setup is for common surgery like traumatic, degenerative, infective, and low technically demanding surgeries. I am happy with the Indian, and most of my cases, 95% of my cases is Indian. Thank you. I thank Shailesh, Sancheti Hospital, Ortho TV, and regards to all the panelists. Thank you.
I know. Thank you, Dheeraj, for a very well explained talk. As we have to use mix and match at various situations, sometimes we have to use hooks at the top, Indian, imported, cobalt rod. I would like to ask Raghav sir to give his comments, and we will have 1-2 comments after this also.
I thought, Shailesh, that the discussion should be on technical matters. I think affordability is not a question to be discussed at all in a forum like this. I don't think that is right. But people like us who have started our careers, started spine surgeries, I should say, in India in the early 90s, we had no Indian implants available other than hard-shell rectangles and sublaminar wires. The pedicle screws actually came into existence 2-3 years later after we started our practice, and we just had at the time. So when you talk of implants between Indian and imported, first and foremost, there's no medical legal issue anymore, because any Indian FDA approved implant, if you use it, there ends the matter. There is no need for you to defend yourself because you have used that implant. So surgeons who are using FDA approved, Indian FDA approved implants, there is no problem, number one. And in my days when we started, we used to have inni and outie. Some of you guys, senior surgeons would know. And after putting the screw, it would take half an hour to put the inni and outie on 2 screws. But those days are gone. Today, our implants, Indian implants, are pretty good. I have yet to, in the last 600 surgeries that I can think of in my unit, I can't think of one problem with the Indian implant, nor with the imported implant. That means our implants are matching. If there are failures, there are technical failures. Sometimes infections cause problems, sometimes osteoporosis causes problems, sometimes fusions fail, like we have seen before. These are issues that are inherent in the surgery itself, or perhaps patient issues, but per se, implants failing is not an issue anymore with the Indian implant. For those of the youngsters to choose, you have to be careful because some of the Indian manufacturers are bringing titanium from China. That is something you have to be careful. If it is a German titanium that they're using, titanium alloy, that's what I mean, there is no problem whatsoever. And today, to avoid the confusion, that's the debate, there is no problem using the Indian implant. I will never go into the cost. If the guy can afford, we'll use an imported implant. If the guy can't afford, we'll use an Indian implant. Always choose the instrumentation that comes with the implant. And for example, if you see the Medtronic, the top nut cutter, it's so hard. On a small child, you're doing it makes so much noise. And some of these Medtronic implants also, sometimes we feel Globus is better than Medtronic, as an example. And for those who can't afford, we have Korean implants also, which are pretty good, though the range is a bit less in our country. So by all means, Indian implant is as good as the Western implant today. There's no advantage. Use the implant with FDA approval, and always, to say that imported implants have a good range and good, backup for rescue screws, etc. Please don't believe that. Half the time, I can give n number of examples where the Indian implant sets are far superior to imported ones. Having said that, my practice is almost 70% imported and about 30% Indian. I go by the, the patient financial status. But every patient, I offer both and tell them that Indian implant is as good as the Western implant. Last but not least, I would only used to worry about the pedicle, the screws in the cervical spine because they were tiny, and I was worried initially. But again, using Indian the laminar screws, the lateral mass screws, etc., the Indian implant has not failed as far as my unit is concerned. So no difference, perfect.
I think are we biased when it comes to affordability and price, and we talk about and if the patient is your own known or very close to you, you chose to prefer some particular implant, and why so? Why there is no uniformity in preferring Indian implants for most of our patients? That's again a dilemma, and in everyone's because patients are reading on the internet, they know various different implants, and they come with a choice. This is what I want. And whether it is the industry, which is because India is a very big country, 140 crore population, the Western world is looking at India as a big market for this. So why not Indian companies should have come up with make in India concept and come up with as good as all Western implants? Yes, Bhavuk.
So I have a couple of comments to make, Shailesh. The first thing is, as you know, we all use the hybrid implants. So we use Indian implants as well as the imported implants. So for like Dheeraj rightly said, for low stress conditions, Indian implants, they do well, and there we go by the patient's financial status. And for the deformities and all those things, we prefer imported implants. So there is no doubt about it as such. The important thing is the quality of the titanium is very, very important. So I'm doing a project under ICMR. We are forming a device. So where we try to purchase the titanium for that device. And when we found out, we could find titanium ranging from 100 rupees per gram, per 100 grams to 50,000 rupees per this thing. So the quality of titanium varies tremendously. So this has to be taken care in account. The second thing is the FDA clearance, this thing. So the FDA clearance is, very doubtful thing. Now we have, as Dr. Kiran rightly said, there are two categories, the FDA clearance and there is an FDA approval. So the class 2 devices, they go by the approval called as the PMN, pre-market notification. That means if there is already a device, similar device existing in the market, you can apply for 510 clearance. So that is FDA clearance. Okay, and if you are applying as a new this thing where you require clinical trial and this thing, that is called the PMA, pre-market approval, that is the class 3 clearance. So the 510 clearance is very easy to get, but the important thing is that the FDA clearance is not immune to litigation, while the FDA approval is immune for litigation. So FDA clearance, I have used a company which told me, Indian company, that it is FDA cleared and FDA approved this thing. And when I, my resident was able to bend the rod with his hands. So, there is something, we should not go by just by the FDA clearance. The other thing is CE also, the CE is also, we are getting the implants which are CE approved. And when we go by the papers, then it comes out with China, this thing. It is not European, it is the China, this thing.
Yeah.
So one has to be very careful, when you are looking for the approvals and this thing, one has to be very, very careful.
Yeah, we will ask Umesh from neurosurgical perspective, because what they prefer and their choice. Yes, Umesh.
Well, yeah, Shailesh, I think the dilemma always exists. So we are also, we also use both imported as well as Indian implants. And so far, on a general rule, though there is a difference, I agree there is a difference in the quality of titanium that is used, the quality of standards that are used in manufacturing, the amount of research and the trials that are undergone, in order to, before releasing the product into the market. Definitely, but so far I feel that for the majority of the cases that we use, especially if you can ignore the deformity cases, which I personally don't have too much of experience about, but for the majority of the cases, I think that keep the basics of the surgery standard, in the sense like the basics of bony fusion. The implants have a limited role to play when in majority of the cases, either whether be it in a traumatic spine condition or whether be it in a degenerative spine condition, where we are using it for temporary So as long as our basics or as long as our principles of achieving fusion are strong, I don't, as far as the patient outcomes are concerned, between using an Indian and an.
Okay, thank you, Umesh, and we would like to ask Siddharth what is his take on this. Yes, Siddharth. No, you are not. You need to unmute. Yeah.
No, there's a slight lag in my internet connection. What was the question?
What is your take on this?
So I completely echo with the panel discussion. I think for complicated surgery or deformity, I think there is definitely an advantage with foreign implants. But for routine daycare, routine infective trauma conditions, I'm happy using Indian implants. Obviously, you offer the patient the choice and let him make a decision, and he has to have his say in it. I have a few slides on this in my talk, so I'll leave that for the time being.
Perfect. No.
Shailesh, I think, sorry.
Yeah. Yes, sir. Please.
See, I think what is important, why, we have huge experience in deformity corrections, and our center has done, huge numbers over the years. Now, even in deformity corrections, right, we didn't have failures of the Indian implant.
Yes, sir. I was to tell the same thing. I totally agree with you. What happens is,
I tell you, what happens is most of these parents, right, when they bring children, they say, doctor, please use imported implants, small child, I don't mind spending under 1.5 lakh rupees. The only place import implants, the advantage over the Indian implant is the instrumentation. For example, if you're doing an osteotomy, a pediatric spinal deformity osteotomy, you got far better instrumentation when you use the imported implants. So when we are using the rod reducers, reductions, the rod reducers, for example, and the derotation instrumentation, that is much better with the imported implants. That's why we prefer to use the imported stuff. But it is the fusion that is very important. How long will these screws last? As we all know, it takes about 9 months for the fusion to mature max in these kids. So it's always the surgical technique. And today the implant will do very well, whether it's deformity correction or whatever. The instrumentation need to improve, but I'm very proud to say that it's improving by leaps and bounds. What I would agree with Bhavuk, which I don't agree that I would prefer imported over Indian implants on deformity corrections, we have enough experience in this, is that we must ask our big companies, Indian companies, to make implants as good as the Western implants. What I mean by that is to apply, adhere to their standards, the American FDA or whatever, CE standards, not the China CE, the real CE standards. At the same time, we as doctors also should be willing to give money. You can't buy, you can't say I want 4,000 rupees to pay for the screw and it should look like a hydroxyapatite coated 25,000 rupees screw. We can't do that. We should also not criticize our Indian manufacturers. We should tell them, look, you charge a little more, but make it as good as the imported implant. I think we should look for standards.
Point well noted, President. I'm sure that we are getting our confusion sorted of what Ranjeet has created about Indian versus imported. I just would like to ask Professor Shrivastav only one thing. How much is the percentage of failure of implant you tell your patient when they ask whether it is Indian or imported? Shrivastav, sir.
Yeah, actually, in my 35 to 40 years of career, I have used imported implants only twice. I can count the name of the patient also. One of the African patient who was admitted in Hirandani Hospital, and I used imported implant, and another lady where I used the Ducoy anterior plate. Rest all my implant are Indian made, and I can stand in any platform or any situation, and I can speak about the Indian implant. So what Dr. Raghav has nicely mentioned. So you want to try to understand the biomechanics and biology of that patient. It is extremely important. And if we follow these two, I think you would get as good as result as you have from with the foreign implant. Implant doesn't make castle in the air. It's the biology and in your technique which gives you the result. Only twice I have used the whole career. Can you believe this?
No, sir. Yes, perfect. Well said, sir. No, my question is, when the patient is asking, what is your experience of implant failure, whether it is Indian or imported? What is your take, so that we will all understand from an orthopedic neurosurgeon's view?
So I always give them incidence 2% for everything.
Okay.
This is my standard answer to everything.
Yeah.
And it depends upon in which percentage that patient falls into. So you are quite safe.
Yeah, because because then unless we clarify that there is a 2%, 3% chances that this implant may fail and we'll have to revise it.
Yeah.
Because nowadays patients have become very demanding. And thank you for this. We have Siddharth.
Dr. Shailesh, before we complete, what is your take on this?
I think I always give choice to the patient, and I tell them whether you want Indian or imported, because both of them are available with us and both of them are absolutely good in my personal experience. We use a huge number of Indian implants in general. 70-75% is Indian and 25% is imported. But we are so far happy. In special situations, we definitely, yes, as Kiran was mentioning, the cervical disc replacement, we don't have a disc. Indian disc is not there. There are in these situations there is definitely and in some reduction devices we need to upgrade Indian implant. Definitely in deformity we have really comparatively you can really save a lot of time when you use the imported instrumentation. That is definite. Means we need to improve on our system. We are using it because we are trying to save money. Therefore we are spending a lot of time. But if our systems really get to that level, I think that is the right thing. 3 to 4 times of cost will be cut. We can really give a lot of Indians the answer for the money. That's an important factor in our practice.
So are there any situation where the patient can afford imported implant, but you choose Indian?
I think in very few scenarios, if the patient is affording I revised one osteoporotic 4.1 minus 4.1 Tesla T-score was where I used sublaminar wire. In such situation, this patient was affording. I used the revision with sublaminar because the bones were porotic. There was an angular kyphos. There was no option of using. Otherwise, mostly we use whatever the patient asked for. Otherwise, it's a big trouble. Yeah.
Totally agree with Raghav sir and
Ranjeet, my question. So I'm also for Indian implant because most of my surgeries goes with Indian implant and I'm happy with the outcome. But for deformity, we are still not happy regarding the instrumentation side, reduction device, in situ benders, rod rotation devices. All these things are fantastic. Also, I have already told you, while placing a cobalt rod in a titanium head, I think you must also have experience that it doesn't allow to fit the aegis in that case. What is your experience on that?
Totally agree with that. So for my take is that when I don't agree to the fact that complex deformity needs imported implants, given a choice, I will use Indian because I'm much more familiar and conversant with that. The only situation where even the patient can afford imported by choose Indian is in early onset scoliosis and very congenitally VCRs, etc., where the imported screw heads are bigger than what the Indians we have got made. The Indian ones are earlier, before the Indian ones were locally available, the pediatric screw systems, I use imported for them. Because if not, now they're very skinny child, hardly 6 kilos, 7 kilos. The screw head really pop out. Now, the Indian current systems available are much better and lower profile than the imported ones. So since 1.5 years, all the congenital scoliosis, congenital VCRs I've been doing, I strictly use Indian systems and we've been improving a lot on that. And this step, what you said, when you used to put the cobalt chrome on the titanium heads, it becomes a struggle to really get them contoured very well into that socket. But over time, you just stick to one system. It's like you stick to one surgery, you get better in that. So I stick to one system and I try to get out of it left and right, and I kind of become conversant. Second, these pediatric screws, especially if you get the TSRH, they're so expensive, so expensive that, you just cannot afford it. If you go to the pediatric system, that is especially imported for you, or
agree.
licenses, they become very expensive, 35,000 rupees each screw. I can use an Indian screw which 1/10 of the cost. So that's the reason if the patient can afford, I'll go for Indian. Like Raghav sir mentioned, the reduction systems have gone a long way, improved a lot with the company we are working with. You give them feedback. Another thing is that if you give feedback to an imported company, it becomes difficult for them to get an R&D and get back to you. Bhavuk has got a lot of work on that. It's easy for us to get it back to us. Second is mixing and matching, because like what you said right at first go, none of it is R&D for us. It's all copycats. So you can pick up the best part of each company, each system, and make your investments.
I would like to support Kiran for the newer modalities which are coming up big time, the navigation, OAM, and we are doing cervical pedicle screws. And the Indian instrumentation is really not that good. We are using it because we have no option, but it makes a big hell of a difference when we are doing a cervical pedicle screw. You are just seeing it and you are putting it. You are so safe. You are not worried about major issues in subaxial spine also. So this is where we need to improvise on our system. And I think in want of time, I would like to thank all of you, and we will move on to the next debate.
Thank you.
Would like to request Dr. Umesh Shrikanta for the MIS versus open and in spinal infection.
So I'll put up my case.
Yes, Ranjeet, please put up your case, and then we start with Umesh.
So I'll go through, because this is quite a debate where open, where MIS. I'll do a couple of case scenarios, and then the experts can give their final opinion. So these are typical scenarios which when we come to infection spine, could be a paradiscal or a soft tissue lesion, could be an epidural abscess with or without deficit, could be an end plate dysfunction and instability, or could be a deformity, could be like an acute stage or in a heel stage. So these are classical situations how they present to us. Now I'll just go through one of the cases of epidural abscess. There's a young guy, diabetic, came with severe back pain, leg pain, and came with a bladder retention. So was evaluated and you could see a huge, large epidural abscess extending right from L2 on to L5. So earlier days, I would go in and do a laminectomy on this and drain out. So today, I seldom do that. We do multiple port decompression and put a drain. So this is one of the situations where I think MIS is really a boon. I don't know if Bhavuk would be contesting this. And then another case of thoracic spondylodiscitis. Elderly lady in her 80s came with back pain. You can see the defect was having, this was the lesion, came with paraparesis. So paraparesis was aspirated, put on ATT. Biopsy was done, put on ATT. In spite of the pain worsens, went ahead, I did a first stage back, and then I did a minimally invasive thoracic corpectomy and did a reconstruction. This was his posterior MIS with anterior second stage. This was another situation, again, a patient of lumbar spondylodiscitis. In these cases, you can debate, do you have to do MIS? For want of time, I'm not going to the question because it might take time. I think Umesh and Dr. Umesh and Dr. Bhavuk will be deliberating as to how they decide. So based on this, I decided that this case, I was not very sure. I thought I'll do a back and see MIS. So went ahead, this was a CT with the amount of destruction seen. This is what we did. They went ahead, did an MIS fixation on one side and did the debridement, did a port tube decompression, put in interbody grafts at that level. And again, this came out to be pyogenic discitis, not tuberculosis. And another one, post-op discitis. Today we guy and do olive in this now, not really much, but still this was tried. Then again, another occasion where elderly, 69, back pain, leg pain. This was the discal lesion, was looking like the CT guide biopsy was attempted, but nothing could be got. Went ahead, did he had severe back and leg pain, did an MIS telephone on him, and again this came out with tuberculosis. So these are the different situations wherein you go in for full-fledged MIS. Also, there are situations where we have purely back pain with a discal lesion, nothing, no instability, just want to get a tissue. The actual MRI did not show much of soft tissue, more was a discal infection, wherein I went and did a endoscopic transforaminal debridement and got the tissue. It came out to be pyogenic discitis. So we'll not go into the literature because we have the master speak on this. With this, we'll get into the debate by our dear friend Dr. Bhavuk as well as Dr. Umesh, who will tell us when to do what. Thank you.
Yes, Umesh, please proceed.
Hi, thank you, Ranjit, and it's been quite a pleasure. Uh, you know, so whenever you introduce me for any debate, and I'm always very cautious these days because you always have some quirky questions for me at the end of it. Well, thanks again, Pune Orthopedic Society, Maharashtra Orthopedic Association, and Dr. Shailesh especially for giving me this opportunity. My topic is on infective spondylodiscitis and what is the role in today's age of MIS decompression, bar biopsy, bar lavage, whether it is sufficient in many cases, and to address the questions of why, when, and what. So as we know, infective spondylodiscitis is a group of disorders due to different etiologies or different infective pathologies. It can be pyogenic, it could be granulomatous as well as parasitic. I am not going into details about each of these individually, but overall, to consider them in together, we see that the treatment goals predominantly are to identify the causative organisms and its sensitivity, as well as to eradicate and cure the infection. And both of these are achieved either by just a biopsy culture or just a minor, decompressive procedure, or by medical means. Now, in the underlying rule of all these infections is that given an appropriate as well as an adequate dose and an adequate duration of the correct antibiotic, so all of these infections are going to get cured. Our goal is during this period, during the time that this infection gets cured, is to maintain or restore spinal stability and balance, and maintain or restore neurological function, and during this process to alleviate the patient's pain and to make the patient as comfortable as possible during this period. Now, I'll not be going into the details due to lack of time about the indications for surgical intervention per se in spondylodiscitis, but to just to briefly say, see, if you consider majority of the early indications for surgery in spondylodiscitis, you would see that majority of them are just aimed at the either diagnosis or for decompression of a granulation tissue or a neural tissue, and to reverse any neurological deficit that has caused, or any aspirate any abscess that has caused. Only very rarely do surgery is being done for back pain, for severe back pain in early stages. But as we progress, or as we deal with more and more severe or destructive infections, like more of intermediate or more of delayed cases where there is significant bone destruction or lysis, only in those cases where surgery, where radical debridement or stabilization or deformity correction becomes the main cornerstone of surgery in these particular cases. So majority of the early cases can be dealt with just a decompressive procedure or a diagnostic procedure and medical treatment alone. Now, if you go into the obvious trend that we are seeing nowadays, so we hardly come across the type of cases that we see our seniors showing us, in the sense like 3 to 4 vertebral bodies that are completely destroyed with a large abscess, with severe compression, patient paraplegic for 2 months. I think these cases are becoming rarer as the days progress, and we are detecting more milder infections, because not only because of the increased incidence, but maybe because of better understanding of disease even among the general physicians who have a high index of suspicions in high risk groups, who can do an early diagnosis, because of easy accessibility of an MRI, we can diagnose these infections early. And this trend, as combined with the advances in minimally invasive techniques, that is rapid rise of endoscopic applications as well as higher adaptation of tubular retractor, probably it is easy to surmise that there is a reduced need or incidence of radical surgeries in the present day era. Now, there are several different options for MIS as far as spondylodiscitis goes. CT-guided biopsy is helpful in achieving a diagnosis. Tubular decompression may be required for achieving a diagnosis, as well as achieving decompression probably of a nerve root or probably of a thecal sac at the same time. Endoscopic interlaminar decompression, people who are well versed in endoscopy, who have good experience, can claim that they can achieve a similar degree of decompression that we achieve with an endoscope per se. Whereas what has made actually a difference is a transforaminal endoscopy. Transforaminal endoscopic approaches in spondylodiscitis, which is predominantly an anterior disease. Considering if you just neglect the epidural abscess, standalone epidural abscess, so it's predominantly an anterior disease which is paradiscal or discal. And these are better approached or better tackled with transforaminal biopsy, which can be done under local anesthesia as a daycare procedure. It gives good direct visualization, direct into the disc space. You can achieve a good intradiscal decompression, which has been shown to have good pain relief as well. We can do a good drainage of the paravertebral collection if required. And it's a preferred choice for biopsy whenever radical decompression is not required. Now, there are extended endoscopic applications, where we can even do a peridural or an anterior epidural collection can be drained using a transforaminal endoscopic approach using an epiduroscopic method, or even by using a biportal approach and suction irrigation drainage, you can actually achieve good results for endoscopic drainage, as has been shown in this particular study, where 100% success rate was achieved in a small group of 26 patients, by using a biportal endoscopic drainage as well as postoperative suction drainage. And literature also is abundant with evidence that percutaneous endoscopic discectomy and drainage has got a high diagnostic yield, not only to diagnose the etiology, which should be considered prior to extensive anterior surgery, but also in relieving patients' symptoms like back pain or achieving some amount of thecal sac decompression, as far as in many of these cases go. And also the recovery rates in percutaneous drainage or percutaneous endoscopic drainage is similar to that of an anterior interbody fusion, and it is better than just a standalone posterior decompression and fusion or conservative procedures per se, as shown in this particular study. Now, but we are not talking about a uniform group. We know that spondylodiscitis is a heterogeneous group, and we have a variety of a different spectrum altogether, standing from just isolated vertebral body signal changes with a small epidural abscess, small disc space, paradiscal collection, to a significant vertebral body destruction with spinal instability. So we cannot uniformly categorize these patients into a single group and say, okay, this is the best method to treat such cases. So we have categories, and of course there are clear indications as far as goes. I'm sure Dr. Bhavuk will agree with me when I say that there are certain conditions where the decompression or lavage alone is significant, and I'm sure that I agree that there are cases where decompression or lavage alone is not sufficient, and a fusion, a concomitant spinal stabilization or a fusion procedure is required. So, but what we are actually debating is what is the gray zone, that is where there is no clear indication as to which is the better technique in order to address this spondylodiscitis concern. So just to go into a little bit detail, we know that clear indications for decompression or lavage alone is, when there is just a diagnostic biopsy that is required, when there is just a spondylodiscitis with no significant collapse, no significant epidural abscess, we just need a biopsy in order to find out the causative organism. Predominant epidural abscess, as we can see in this particular case, with no significant bone destruction, no significant bone involvement, even with deficits, these just with decompression and just with a good lavage, identify the organism, postoperative antibiotics, these things are going to cure very well. A stable spine, despite focal bone destruction, there may be a focal bone destruction, but a stable spine, again, we can just tackle these cases by simple decompression, diagnostic pathology, as well as postoperative antibiotics. Even in advanced cases, there are several cases where patients, if they have minimal mechanical symptoms, no neurological deficits, no spinal deformity, and moreover in patients who are very old age group, who are not fit for a major surgery, again, minor decompression as well as lavage is sufficient in these cases. So this is one of our examples. Unfortunately, postoperatively developed after a tubular discectomy, developed a postoperative spondylodiscitis. You can see the amount of infection, the amount of epidural adhesions, the epidural inflammation that is there. We just did a redo MIS MLD. We just did a biopsy, give a thorough wash, culture proof, which we expected proven to be MRSA. Gave postoperative antibiotics, follow up after 2 months, and there was no infection or instability in this particular. So majority of these cases, there, simple decompression and lavage is sufficient. Of course, there are cases where, there are clear indications for radical decompression or fusion, and Dr. Bhavuk will be covering in more detail with this. Again, it's not necessary that we need to approach these cases in an open fashion. So this is one of our cases where we did, again, a minimally invasive decompression of the neural elements, as well as restoration of spinal balance, in the sense like spinal stability was restored with a minimally invasive technique. That also can be done. And what we are actually targeting here is the gray zone. And majority of these cases, what we are dealing with is an intradiscal abscess. I think Ranjeet also gave an example of such a case where there is a significant intradiscal abscess with end plate destruction, and patient also presents with mechanical back pain. So what is the ideal situation or ideal treatment strategy in these particular cases? So there are options. There are options of like percutaneous endoscopic discectomy can still be done in these cases, which is still minimally invasive. It can be done as a local or a daycare procedure. Decompression and biopsy can be achieved at the same time. And we already know in the literature that there's a good relief of back pain after such conditions. And the intradiscal lavage also can be given. The alternative is stabilization, which can either be from, usually in such cases, from L4 to S1, which can be done either with a T-lift, with an MIS, or an open approaches. So this is one of our cases where, example, paired biopsy, spontaneous discitis in an immunocompromised patient, where significant infection, significant paradiscal destructions. Of course, he was a poor surgical candidate, but good results can be achieved just by PLD biopsy. It came as MSSA, antibiotics for 6 weeks, follow-up. He was completely normal. This is again, case that I inherited post-operative discitis for a surgery done elsewhere. Again, empirical antibiotics were given. It was a delayed discitis. It shows the importance of getting a microbial culture in all these cases. We did a PELD, gave a thorough wash, give percutaneous drainage, percutaneous wash with betadine hydroxyperoxide, as well as give almost 1 to 1.5 liters of saline wash. And the organism in this particular case was Burkholderia. It couldn't be further characterized in our institute, so it was labeled as Burkholderia, and it was treated further with meropenem and cotrimoxazole for 6 weeks, and after that he improved significantly. These are the post-operative images showing significant improvement in the infection. So even significant, paradiscal destruction with mechanical symptoms can be treated conservatively. Again, this is one of the examples that again Dr. Ranjeet was putting up. Focal bone destructions. There is a significant abscess cavity within the bone. I'll not go into the details. So again, this was particularly managed by just a decompression and a biopsy. Histopathology was tuberculosis, started on AKT. This is just a recently done case. So we had a similar case almost around 2-3 years back, which was managed similarly. So this is a case which has been doing so far, very well with no further neurological deficits. And he has significantly improved as far as the preoperative neurological deficits are concerned. Now, this other gray zone is when the initial culture or biopsy is negative on the first time. So in these cases, we are again, back to square one. All of us are just, stuck in this pickle where whether to do a redo endoscopic biopsy, whether we can sample a different area. In these cases, it's important to do some kind of an antibiotic suppression prior to doing a second surgery, and to take samples or punches before starting our saline irrigation. Open radical debridement and stabilization, of course, is a very good option in these patients, and the decision is often based on the extent of bone destruction, spinal stability, or presence of this one. Major neurological deficit in a patient is stable spine. Decompression is the primary treatment, but of course, we are all aware, of our own study from Dr. Nene, who has shown clearly that especially in tubercular etiology, even when with a significant deficit of less than 3.5 or even up to 3.5, less than 3.5 was their indication for surgery, up to 3.5 or kyphosis more, less than 40 degrees. And non-progressive neurological deficits can be managed conservatively with excellent outcomes. And decompression in these particular cases, even if needs to be done, is a very good option rather than doing a radical debridement and fixation for these particular cases whatsoever. So again, one more clear-cut etiology that we come across is a moderate persistent mechanical back pain who has been on antibiotic therapy for certain duration of time. In those cases, we have to assess the response to the antibiotics. If there are any active lesions, if their active lesions are healing, naturally, it's a case of post-infectious instability, and of course, fusion or stabilization is going to help in these particular cases. But if we feel that in the follow-up there is no response to the antibiotics, of course we need to reassess our treatment strategy. If there are fresh active lesions that are appearing on an MRI, we need to do a redo biopsy or a culture and change in the entire management protocol. So this is one of our cases. This is much milder than what the cases conservatively managed cases that I showed earlier. But this patient was on AKT for almost more than 3 months, and it's a biopsy-proven tuberculosis. And patient showed no improvement in mechanical symptoms. Despite 3 months, she came back to us on a wheelchair, and there was no option. So we just had to do a minimally invasive, MIS TLIF at that particular level with above and below decompression. So to summarize, there is no optimal or universal strategy for spondylodiscitis, and we need to categorize or individualize our treatment plan based on what is the presentation, location, the organism, the nature of involvement, as well as the neurological status. So naturally, the present trend is we are detecting a higher number of infections, especially in an early stage. And these can be effectively managed if diagnosed early in a proper way, can be effectively managed with minimally invasive or endoscopic techniques. And the whole plan should be based on we should plan early and we should plan small rather than going big in the first stage itself. And nevertheless, appropriate as well as adequate, as I already stressed, antibiotic therapy is still the mainstay to achieve cure in these particular cases, irrespective of the surgical strategy that we employ. Thank you.
Great presentation, Umesh. And in this clash of titans, the last debate, we invite Dr. Bhavuk Garg for his views on fusion in infective spondylodiscitis. Yes, Bhavuk.
Thank you, Shailesh. So my slides are visible?
Yes.
Yes. So this is the topic which I was given, that why I think the thorough debridement and fusion is better in spinal infections vis-a-vis the MIS. So certain disclaimers. So I'm an orthopedic surgeon by training, and no offense meant, but as an orthopedic surgeon, I think we understand, and we have seen the bone in almost, in every form to our mind and soul. And we have been taught that whenever you see an infection near the bone or inside the bone, you treat it as a malignancy. You have to be thorough this thing, because the bone sterility is like virginity. Once lost, it's lost forever. So this is my disclaimer that I am an orthopedic surgeon. So my views may be a little bit biased as an orthopedic surgeon. And I love MIS. I'm very much into the minimally invasive surgeries, especially when properly indicated. So coming to this thing, infection in spine surgery, if we look at the broad perspective, the spectrum, these are the kind of infections which we usually see when we talk about infection in spine, ranging from pyogenic spontaneous to tubercular, parasitic, spinal epidural abscesses, non-complicated spinal discitis. Complicated spinal discitis means when they are associated with neurological deficit or instability, and then comes the post-operative, which can again be with or without implants and superficial and deep. So the most commonly we see the tubercular infections and the non-complicated spinal discitis one, which forms the major of our patients. And the goal of treatment, it is already well known to us, that remains the complete eradication of infection, preservation or restoration of the spinal structure and stability with neurological status recovery and relief of pain and return to function. But the important thing is to realize that most of these patients, they can be treated conservatively. Conservatively, management works. In pre-chemotherapy era, we used to go for radical surgery and there was high morbidity. The 10% of the patients with pyogenic spondylodiscitis, they require surgery. We know about the middle path regime in spinal tuberculosis. It works very well. The ambulant chemotherapy is the first line treatment for this thing. And there are selective indications for surgery, and has worked well for us in our experience well past in India. So this is a very important paper which came, that is aggressive surgery is necessary for acute post-operative deep spinal wound infections. It has also shown that the antibiotic treatment may be effective in the treatment of acute this thing. Not all patients, they require the big surgery. So this is my own case. This was done as a case of microendoscopic discectomy. So Professor Jaiswal was the pioneer of minimally invasive surgery in India. He started the microendoscopic discectomy in 2001 in India, and I was his first postgraduate to do the thesis on microendoscopic discectomy. So this was the first, the first series of this thing which was published as a the minimal invasive surgery from India. So this was a case of microendoscopic discectomy, and he developed discitis L4 L5 after 6 weeks, And this was well treated by, these are the post-contrast images, and he was well treated conservatively just with the help of the biopsy diagnosis and just the antibiotics, and he healed by fusion, at 1 year post-op. So the conservative treatment works. Now, if we look at the pyogenic spondylodiscitis as such, this thing, so this is a very good paper which have seen, and they have divided into, the sort of classification, and they have shown that the MIS decompression would suffice only in very selected indications, which forms a very few actually of your patients who fit into your surgical indications as such. And they have also recommended these are this thing. So again, if you look at this thing, so as such, the minimally invasive decompression alone doesn't stand anywhere. It is always combined with the stabilization, and we know that as an orthopedic surgeons, that the stabilization is very important for healing of the bone. This is our series. It is under review. This thing in a journal. It's a large series of 1652 patients of spinal tuberculosis, and we have looked at the indications of surgery. So out of 1652, we just operated 173 patients, and these were the indications. So if we look at the indications of MIS, which could fit somewhere else, is only this one, when there's a failure of response to conservative treatment at 12 to 16 weeks. So if we look at the indication of surgery, Dr. Shrikanta has already covered this thing. They can range from neurological to the non-neurological indications. I'm not going to detail, but this is just to show you an example of a tuberculosis case, which I operated just yesterday, so I could take the pictures. So you can see here that this was a case of we were lost the posterior tension band and this thing. So there was an abscess. The important thing is just I wanted to show you that the amount of muck and the scar tissue which we usually observe in tuberculosis is this thing. You can see that this scar tissue is, we all know that it is completely stuck to the cord, and it is very difficult to remove it even with the open surgery, So I'm not sure that how MIS will be, this thing when the scar is constricting this thing. So, and it is over a large area. So I feel the MIS would not make a much better indication for me at least. And I will always prefer to go for an open surgery in tuberculosis spine, especially if such granulation tissues are there. Now, this is another case, like Dr. Ranjeet said, the epidural abscess. So if it is just limited to 2 or 3 levels, then yes, MIS can work. But again, when it is tuberculosis, I am a little bit skeptical. I am not sure whether it's a liquid abscess or it is going to be again a granulation tissue, which is causing a scarring effect. So I have to take it out. So again, my preference for these epidural abscesses always remains an open one. I open a small one. And if I am doubtful, if I am this thing that there is, that is just a liquid pus, then I just pass this, this red rubber tube catheter, and just I can get away with this thing. But again, I would like to see with my eyes that, that it is not a granulation tissue or the scar tissue is there. So if it is multi-level, then again, I will not waste time in putting so much cannulas and this thing with open. I am very quick, which is again a very important fact, because these patients, they are often, in a septicemic state and they require quick surgery. So somehow I do a lot of minimally invasive surgeries, but I still feel that I'm very much quicker with open surgery as compared to a minimally invasive, especially if I'm talking about the multi-segmental ones. Coming to the post-operative infection in implants. So whenever there is an implant, there is no question about it. I don't think even about MIS. I always go with the thorough debridement and the fusion. We ourselves have done this study. We have shown that the biofilm formation occurs in the commonly used orthopedic metal implant materials. And as the titanium and the cobalt chrome, they are the major ones. So we have shown that with electron microscopy, we have shown that the bacterial adherence is much more with these materials. So I will not go for minimal invasive. I will just do thorough wash, lavage, and everything. So whatever I can do, and there are indications of retaining in this thing. I'm not going to detail this thing. And again, you have to resort for the various other methods to tackle these cases. Now, when we talk about the parasitic infections, I think there is no argument that the minimally invasive has any way. This thing, they again require a thorough debridement in this thing, and this was a case of hydrated cyst, which was again, it has to be taken care of with the open thorough debridement and reconstruction. If we talk about the MIS options, Dr. Shrikanta has already told that there are various options. And, if we look at these studies, they again, they always excluded, there were certain riders with them. They excluded patients with neurological deficit. And again, these are various methods which have been described in literature. So the evidence is always rigged, the positive findings. So the studies which report that they have got better results with minimal invasive, they tend to be published more. We know that this is a problem with the bias in the literature is there, but there is no quality level 1 or level 2 evidence available to demonstrate the benefit of MIS. And again, there are options to conversion to open surgery as well in these studies. So although this is a debate between the MIS and fusion, but ideally the debate should have been whether between MIS and conservative. And in what percentage of patients who strictly meet the criteria of surgical intervention would you favor only MIS decompression or our open MIS surgery with fusion? So this is the important thing to realize, that minimally invasive surgery was offered as an alternative to conservative treatment in early and non-complicated forms of pyogenic spondylodiscitis. And these are the different, the literature which I've taken, that, without significant neurological deficit, without any the instability. So most of these patients, they can be managed with conservative this thing. So this is a very important paper which I could find, which have compared the decompression alone versus fusion. And it was not again a cohort study, but it was a dual presentation of case series, and they have looked into they did the decompression in the cases without instability, and they did the fusion for cases with instability. So again, these cases in which we are doing the MIS decompression, probably they may not need surgery at all, and they can just get away with conservative treatment. So this is just an example of this case which I've taken from this article, case where they just did the decompression minimally invasive, and they showed that the results are good. And this is my own case, in which the similar case in which I have used just the conservative treatment, and the patient was well after 6 weeks without any surgical intervention. So the indications of as an orthopedic surgeons, we always say in our parlance, that if you have a hammer, everything looks like a nail. So one has to be very careful, whether these patients, they actually need surgery or not. Now, this is, and again, a good paper which have compared the 75 minimally invasive versus 73 open. And again, the surgical treatment, whether the MIS or the conventional, is dependent upon the individual decision of the surgeon. So this is, Rishi would agree with me that this is called the quirky behavior, quirks of a surgeon, where the surgeon's training and his beliefs, they come into play, whether he is going to for the MIS or the conservative. And again, the MIS groups, they have the longer fluoroscopy time, higher radiation exposure. There was a probably shorter operative time, lower perioperative blood transfusion. But again, the question remained whether these patients, they required surgery at the first place or not. The open surgery was favored more when the paravertebral abscess or the multisegmental disease was there, which we already know. The another thing which I identify with MIS is a steep learning curve. People have shown that the overall postoperative complication rates are much more in surgeons' initial cases. So one has to be very, very careful when using MIS, especially in infective cases where it may be difficult to identify the anatomy, or this thing is already difficult. So one has to be very careful. The another thing is the adding value. We need a higher cost of technology, equipment, increased OR times when we are going for minimally invasive techniques. And it can be difficult to implement in resource constrained settings where this spondylodiscitis is more common, because at the first place, the infection is very rare when we talk about the modern theaters. This is our own experience. So we have also published the outcome of minimally invasive surgery in the management of tuberculous spondylitis. This is the paper which we published in 2011, and it was a retrospective analysis of patients. And in group 1, we went for the video assisted thoracoscopic surgery, and in group B we went for mini open, the posterolateral debridement for the lumbar spine, and we could found the successful outcome. However, there were some complications, like the 3 patients out of 38, they required the open conversion to open surgery, which is again more than 10% this time. So if we look at the overall goal of our debridement and we compare the MIS decompression versus open fusion as a head-to-head comparison. So the first goal is the debridement of diseased tissue. With MIS decompression, yes, it is easy access to the epidural abscess, posterior elements. It may be difficult to access tissue ventral to the cord, and access to anterior paravertebral abscess and tissues, it is not possible. The open fusion, yes, thorough debridement is possible. Sampling for diagnosis, both the techniques, they share the equal thing, the equal status. When we come to the neurological decompression, again the ventral decompression may be difficult, especially for the youngsters or the people in the learning phase, and it's difficult to deal with sequestrum, the bony stenosis, or the internal gibbous, or which we talk about the scar tissue. And the open fusion is versatile; it can effectively achieve the circumferential decompression of cord, and you can remove everything: bone, soft tissue, scar, everything. Stabilization, again you need percutaneous screws when you're talking about the MIS. And open fusions, yes, you have plethora of this thing. Besides pedicular screws, you can also use the wires, you can use the hooks, or whatever laminar screws we are using now. So you can use anything. The anterior column is already compromised, so again you have to be very careful. Deformity correction is not possible. Percutaneous, with you can achieve a mild deformity correction, but for a moderate or severe kyphosis, you need the open fusion. So I think if you look at the head-to-head comparison, you can yourself see that the open fusion has this thing clear advantage. Most of the existing studies have described the MIS decompression for patients that we routinely manage conservatively. So MIS decompression you can consider as an alternative to conservative management in non-complicated TB, can be considered for selected patients with complicated TB, like single level posterior involvement, spinal tumor syndromes, VETs for large thoracic abscesses when there is no mechanical instability, or in elderly moribund patients. So one has to keep these things in their armamentarium as well. But the foremost principle is that the goal to perform is you have to establish the surgeries which are validated and effective in a less invasive manner. Avoid minimally invasive, minimally effective procedures, and must remember that if a procedure doesn't make sense with open technique, it doesn't make sense with the MIS technique either. So I'm not going to change anyone's perspective. This is my perspective. This is my understanding as an orthopedic surgeon, this thing. So if I have to say one thing, one word, the role of MIS in spinal infections, I would say the cautious optimism is the word to remember. Thank you.
Thank you, Bhavuk, for a wonderful presentation. And
excellent talk.
I think we really are close to understanding about the confusion which Ranjeet has created, and he put the ball rolling. And this was
Shailesh, can I ask a question to Umesh?
Yes, please.
Yeah. So Umesh, so most of our practice TB presented late and usually with some neurology, or they have been already on AKT, and so most of these cases, even not even 5% or less than that, they they have frank abscess, and most of them have associated approval granulation tissue, which is adherent to the cord. So how you tackle this? I can understand endoscopy as a good technique alternative to biopsy, but for decompression, I'm worried. Yeah.
See, I'm not an endoscopic surgeon, so I have limited experience in endoscopy as much I have with the tube. So I'm basically a tubular surgeon. Now I talk to other endoscopic spine surgeons, and they come and tell me that they are able to achieve a similar amount of decompression that we are able to achieve with a tube with an endoscope, whether it's an interlaminar endoscopy or a percutaneous, and it's just a difference in the gap. So maybe I feel that somebody, maybe there is, if I feel that I can achieve a certain amount of decompression with a tube, maybe somebody else is not able to achieve the certain amount of decompression with the tubular retractor. So there's just a gap, what I am not able to achieve today with an endoscopy, maybe, it's just a gap that, that all of us, we are going through in the face. So that is number one. Number two, the question that you asked was, granulation tissue in tuberculosis. So especially, of course, we can deal with, now there are enough reports of us dealing with, OLFs and, even spinal tumors, intradural, sometimes intramedullary spinal tumors with a tube. So naturally, it is not very difficult to achieve a certain amount. I'm not telling as radical as we could do in an open. But yes, whatever was required, its case selection is very important. But yes, whatever could be done with a tube, at least 2 segments, easily we could decompress with a single incision with a tube. And even if multiple segments have to be decompressed, we can do it with a multiple incision. It takes some time, it takes extra time as compared to an open surgery. And if it's a moribund patient where we need to do a quick in, quick out procedure, naturally it is not advisable. But I'm not telling that, MIS is good for all particular cases, but naturally over a period of time, we are seeing increasing incidence of usage of MIS approaches as compared to an open decompression. So whether it is, whether we are doing an open surgery or an MIS surgery, the amount of visibility, the amount of tissue that we are handling is the same. So we will be able to see the same amount of granulation tissue with a tube as we are able to see with an open surgery. We will be able to see, I think Dr. Bhavuk mentioned that we will not be able to access the ventral to the cord tissue with a tube. And I feel that it is actually easier to access ventral to the cord tissue with a tube than, in my experience, I would rather approach it with a tube than with a, in an open surgery, because, a tube you can easily come from lateral to medial and dock it anterior, and you can easily visualize the structures that are anterior to the cord. It's easier, I feel that it is easier to decompress structures that are anterior to the vertebra. Anterior vertebra, I showed you an example where we have done a corpectomy through an MIS technique. So with adequate technical applications, I don't think it is difficult to achieve what we are achieving with an open technique, with an MIS technique. There are limitations. Even today, yes, even I do an open surgery every now and then. It's not like I do all my 100% of the surgeries as an MIS. But I feel that over a period of time, given sufficient experience and given sufficient technological advances, we should be able to tackle most of these cases through an MIS technique.
Yeah, point well taken. And it was like a IPL match, Delhi Capitals versus Royal Challengers Bangalore, and we really enjoyed it. But before now, we would like to know from the man who was not confused throughout the debate, was researching for last 2 weeks, is Siddharth Iyer, and we would like to know why was he not confused. Yes, Siddharth, over to you before we proceed.
Thank you for the opportunity to speak. The topic so far that we've discussed has been quite in depth, and it's been quite academically heavy. So my talk is going to be more philosophical. So my brief today is, I am no longer confused, and I have to explain myself. So I think one of the most dangerous phrases that we use often is, we've always done it this way. I think there is a hidden problem with this, because everything is subject to change and nothing is going to be permanent. So just because you have done it this way may not be the best way to do it henceforth. That is one thing we need to know. And that is the essence of today's debate, to see another man's perspective, to take the positives from his perspective, to modify your own perspectives if it is suitable enough. And yes, you end the day and make the decisions that you are comfortable with. But then there's no harm in listening for another man's experiences. There's always something to gain from all this. So there have been 17 different routes that have been charted to summit Everest. If you consider a good surgical outcome as the success of your surgery, as the summiting of Everest, there are various ways up that mountain or up that success tree. You can use the southeast ridge, which was famously taken by Hillary and Norgay in 1953. But then you quite often don't forget that in the northern ridge, George Mallory went 800 meters shy of the summit, way before them, nearly 30 years before. But still, both the routes are still used to summit Everest. Each of them have their own downsides. They may have their own upsides. So coming to the first debate, anterior versus posterior approach to the TB spine. If you look at trending literature in TB spine, even today, the maximum citations for TB spine are with Hodgson's original paper, where he discussed radical debridement of transthoracic approach. So that still holds true. The direct decompression that you can achieve of the cord with that type of procedure is unmatched. But very early in the entire process of the evolution of TB treatment, with the MRC trials, they realized that a radical debridement is not always necessary, and sometimes a slightly conservative debridement is also enough. So very early in the anterior surgery phase itself, you went from a radical Hong Kong to a modified Hong Kong. So there itself, I think the pioneers of that surgery realized that utna karne ka to jarurat nahi tha. If you take that further, in vintage cars, there were doors that opened backwards. These were called suicide doors because they felt that these cars are liable to be having high risk of accidents. So this was phased out. But then even now, sometimes the Rolls-Royce has a phantom car that is coming out, which has a backward door. So there is a role for anterior surgery even in today's date, because if Rolls-Royce can still have a backward door on their latest convertible phantom, then I think we should also keep in mind that the anterior surgery does have a role to play somewhere. So what is the consensus statement? Okay, excellent exposure and debridement, that's fine. But if you look at the papers coming out for only anterior, I think they have dwindled past 2000. The maximum number of literature that came out was probably a decade after Hodgson's original paper in 1960. And then since 2000, the number of papers have been reduced. Because commonly all papers have agreed that if you have a large reconstruction or if you have a significant deformity, the problem is that graft subsidence or graft extrusions are quite common with anterior only. Obviously, all my speakers have also explained that biomechanically, anterior instrumentation, whether it's a plate or a dual rod with staple or a single rod with staple, is somewhere less robust than multi-segment pedicle screws done posteriorly, or even multi-segment sublaminar wires done posteriorly. The deformity correction that you can afford through a all posterior is much better. And possibly the maintenance of that deformity in the long run is also much better with posterior only. If you do anterior surgery, quite often you are forced to have a supplementary posterior implants to protect that anterior graft or cage. And as time goes by, one thing is for sure, the anterior approach is less familiar with us newer generation surgeons. We have seen less and we have done less of anterior. And maybe in the years to come, it might get even more unfamiliar for the next batch. So how did this changing of the guard happen? I think it all happened with pedicle screw systems. When CD Corset-Dubusse introduced it, I think it got popular. The more you use a pedicle screw system, the more you open spine posteriorly, you just get more familiar with that approach. I know where the potholes are on my way back from work to house and house to work, and I avoid that lane when the pothole is because I'm driving that same lane every day for the last 1 year. And similarly, because you are more familiar with the posterior approach, you just get used to it and you are now more comfortable. They always say backdoor friends are the best friends. The friend who doesn't show up at the front door and knows you are at the back door, that person is your best friend. And somewhere with the pedicle screw system, that sort of familiarity has helped us grow into a posterior only surgeons. I think this changing of the guard came with the anterolateral extrapleural exposure, which was well popularized by a number of Indian surgeons, Dr. A.K. Jain, Dr. Tulli, Dr. Bhojraj. It gave the best of both worlds, allowed you multiple segment purchase. You could do good deformity correction. You still maintain the correction at long term, and possibly not opening the thoracic cavity or the pleural space allowed you to have lesser ICU stay, maybe shorter hospital stay, lesser risk of complications because you avoided all viscera inside the chest and the abdomen. This was further modified, although in truest sense it still remains posterior, but there are certain modifications. You can do a transfacetal, you can do a transpedicular, you can do a costotransversectomy, you can do transforaminal. But on the whole, they are still falling under the purview of doing something in the anterolateral region of the thoracic spine or the lumbar spine. So even if you look at highest quality evidence, what does a meta-analysis say? So this is 3 randomized controlled trials, 800 odd patients, not significant difference with the in terms of operation time, hospital stay and fusion. But the only difference was how much correction you could get, how well it was maintained. And yes, anterior surgery generally has been seen to have less blood loss than posterior long segment fusions or when a global reconstruction has been done. So current literature, okay, let's take up a review article that is published by Dr. Rajshekharan in the Global Spine Journal. Everyone still agrees. TB spine is a medical disease. Surgery is always reserved for complicated cases. Quite often more than surgery, the main problem that we are facing in India is lack of appropriate medical management, whether it's inappropriate dosing, inappropriate frequency, inappropriate drug choices. I think there is where we are facing a failing battle with TB. I think more than surgery or no surgery is bad medical management. I think the Principles of surgery have remained same, whether it's anterior, posterior, or circumferential: debridement, decompression, and restoration of stability. Although clearly the trend is towards an all posterior approach, and even the panelists who spoke have agreed on this, barring anterior cervical procedure, which still stays, and selected indications where you may have to do as a part of a combined procedure where a very large segment involvement is there, or if there is an internal gippus that you want to address directly over through a transthoracic approach. So my takeaway message: the anterior approach must be a part of the armamentarium that a spine surgeon has. But yes, the posterior approach is definitely more alluring than the anteriors in current day times. Coming to the next set of cars that you have to compare. Do you go for an Aston Martin 21 or do you go for the new 2021 Ciaz? Indian versus imported versus hybrid. So I'll just take a 30-second break.
May I present to you the super luxury yacht, the Nefertiti. Apart from all the luxuries, 6 luxury suites, 3 kitchens, mini golf course, a 3D theatre, 2 ballrooms, and to top it all, it has a top speed of 25 knots.
कितना देती है?
So at the very bottom, for Indian versus foreign and hybrid, whatever you talk about, kitna deti hai is the main question that handles both the patients in the head and both the surgeons at his head. And the cost factor just cannot be negated because it is not something that is negligible. It's quite substantial. Like all the others, I could not find any other literature apart from Dr. Abhay Nene's paper in which he compared 678 foreign with 893 Indian. The Indian screws were all from companies that were CE certified. I am not sure whether it's Chinese, but I am hoping that Dr. Abhay Nene used companies that were European standards. But the failure rates were not comparable. I mean, 1 and 5 still insignificant. So at the end, what is this leap between the failure and success? Bone quality, osteoporosis, infection, pseudoarthrosis, or poor surgical technique. I think these matter more than whether you have an Indian screw or a foreign screw inserted into your patient. Let's look at India's healthcare. I mean, you have to be pragmatic in today's times. We have a high burden of ill health. We have low public spending on healthcare. Most of the patients who have private healthcare are out-of-pocket expenditures. And we have very limited coverage of health insurance either through public sector or through private sector. So this has to impact the implant choices at the end of the day because the patient is not able to pay for the implants himself. What are the concerns with Make in India? We are all for Make in India, but then Dr. Abhay Nene's paper used this word, fiddle factor. The quality of instrumentation has a lot to be desired, but yes, even I feel in my 7 years or 10 years of practice, the quality of instrumentation has definitely improved. Even with Indian implants, what was available in 2013 has improved to 2021. Yes. I will agree with that. So suppose you want to take a Mumbai-Pune road trip, or you have to get from Mumbai to Pune, Wagoner will simply suffice. But suppose you want to get from Gateway of India, Mumbai to the moon, and you have a complicated navigation or a complicated curve to deal with, which has already 3 triple curves going and seeing you. Sometimes you would prefer to use a Star Trek, a USS Enterprise to get across that moon trip rather than go in a Wagoner. So yes, complex instrumentation, if you have affordability, it does help in deformity. And at the end, patient is God. What he wants is the first thing that matters. Takeaway message: let's be vocal for local. Let's talk to our implant companies, tell them, get your instrumentation in order, take the pluses from wherever they can, subtract the minuses wherever they can. Hopefully you're looking at a possibility in the future that for horses for courses, that saying will stand true, not just for Medtronic, Globus and Depu, but also for Jesco, Jayon and Universal. Coming to my last, MIS debridement versus fusion. So Dr. Shrikanta went for this. Less is more. So the pencil is beautiful form and it's perfect function. Nothing generally gets screwed up when you're using a pencil. So what is the current lacunae in what Dr. Shrikanta has shown? yes, the MIS decompression literature is not robust. Whatever Dr. Bhavuk also pointed out, there is no level 1 evidence, there is no level 2 evidence. Most of them are limited to case series. Quite often they are small in size. But I do agree after reading all this that the MIS decompression, whether it's endoscopic or whether it's tubular, definitely lets you take good samples. Whether a biopsy alone will do or an additional decompression helps your patient, I think has to be decided based on each patient. Yes, only decompression to some extent reduces the pain. It does reduce the infective burden. And at some levels, it can be considered to be acceptable drainage. But also, one of interesting scenarios is in certain cases where you have a very clinically moribund patient, debilitated, geriatric, high-risk cases where an open surgery may not be possible, at least for whatever limited debridement or reduction in infective drainage can be achieved, I think is fair enough. And this paper is from a very, very reputed first and second author, which no one can question, Manubo Ito and Professor Abumi. So conventional technique tells us that there are 4 important steps. You have to have complete drainage and adequate debridement. That helps you decrease the burden. You need to identify the organism and you need appropriate antibiotics. I think that stands true whether you debride only or whether you debride and fuse. Eventually, you want a spine stable because stability helps to fight infection, and generally the outcomes of a stable spine will be superior. Most often, infected spine will end with fusion, but it's always a race between whether the patient is willing to tolerate that wait till it fuses and wait for the antibiotics to work their action. And very rarely, if you have complicated cases with neurology or spinal instability, I think there is a need to intervene without any waiting period. Whether you intervene with MIS or open, I think is still a secondary question, but the need to intervene is the most important question there. So fusion definitely has more takers. If you look at Global Spine Journal's recent review, I think 80% of all papers reported on the meta-analysis would go with decompression and fusion as the most preferred option. Whether open or MIS is still open for debate, but yes, recent literature has said that even MIS decompression along with the fusion, definitely no one will take a question with. The problem is whether to do only MIS decompression and not do the fusion. That's where definitely there is a gray zone and not much clarity on. At the end, there are various ways to skin a cat. But as long as you remember the principles of debridement, drainage, organism isolation, appropriate antibiotics, and restoration of spinal stability, most of your patients will do well in the long run. To my penultimate slide, an investment in knowledge always pays the best interests. So we should take this opportunity to thank all the speakers here who have added to our knowledge today and who have helped us get better investments in our academics, at least as far as the 3 debates were concerned. So a big thank you to Dr. Raghav, Professor Shrivastav, Dr. Amol, Rege, Dr. Ranjeet, Dr. Rishi, Dr. Kiran, Dr. Bhavuk, Dr. Umesh, Dr. Dheeraj, and yours truly, Dr. Shailesh Hadgaonkar, for hosting and conducting the last of the Spineconnect series. So I will hand it over back to Shailesh sir for him to take it over. Sir, you're muted.
Wonderful presentation, Siddharth. You really connected the dots which were needed for this big event. And, there were 3 debates and we were really puzzled. And I'm sure most of us have got the gist of it. And we have realized Ranjeet played the part at 15-20 years of seniority level. He was confused and you played a part of showing the evidence and showing the right way to all of us, and which we know, selection of the patient is very, very important. It's not anterior or posterior. It's not MIS or open. It's the patient and the patient type. Indian versus imported was again a very interesting debate, and we got to know a lot about it. I would like to request the chair for today's meet, Raghav sir, for his final words, and we will have 2 minutes from Mrs. Javed from Intas, who supported this event. Over to you, Raghav sir.
Thank you very much, Shailesh. I think the talks were very lucid. That's very important. The messages were very clear. And I think most of us are quite okay with these situations. We know how to handle them. In the last debate, MIS versus open, certainly my own team is going more towards MIS sort of situations where either using an endoscopic procedure or minimally incisions for post-op spinal infections. I think certainly we can relook at managing them. Suppose if there's a disc space infection, we can put a tube, wash it out, unlike in the past when we used to do a lot of open procedures. Certainly it has a role and it pays dividends to do that. As far as paralysis is concerned and mechanical problems, I don't think I will go in for minimally invasive techniques. I'll go the way Bhavuk said, to do a open surgeries and then address the problem and then stabilize them. The most important thing in life is what Cody Bungar said, right? If you look at literature, you can produce evidence either which way. The most important thing is apprenticeship. The most people who are listening to us, the guys who are getting initiated into spine surgery, orthopedic surgeons and neurosurgeons, apprenticeship is the most important thing. When you go to surgeries, when we visit, travel the world, which we do so often every year, but for this COVID, we see their surgeries. The most important place to learn these problems and how the surgeon address is in the outpatients, when the patients come back and you listen to them. So it is not, as Cody Bungar said, it is not evidence-based medicine. It is most important because anybody can produce evidence. It is the consensus-based evidence. When we go to our conferences, there are 600 people sitting in the auditorium. A few of us get onto the dais and we speak, which we do for the last 30 years. Other good patients go back to them. So it's very important to generate consensus. And that's what today's program has done. I think there's a lot of consensus today that is much more important than debating issues for the progress of spine and also for our own country to get better and better and one day to be the best among spine societies of the world. And that should be, and spine surgeons of the world as well. That should be our motto. Thanks, Shailesh. I think you've been doing a wonderful job. I congratulate all the faculty who are all dear friends. I keep meeting all of you, except Kiran and Lingutla. We both live in the same city, but we don't see each other. Very rarely we meet. The rest of the guys, we meet every few months. We hope that COVID settles down and we get back to live conferences. Stay safe and please remember those departed souls, our own friends, relatives, known people who died. Responsibilities as doctors, fight it out. At the same time, let's be responsible to ourselves and to our families. Thank you once again.
Thank you, Raghav sir. Just last 2 words from Shrivastav sir.
Shailesh, I am very, very happy to attend this session. It was really a knowledgeable session, and both part was opened it very nicely. People who are standing on one side and the people who are standing on another side, and both took the cognizance of the other side. That was the beauty of it, because we cannot drift to one-sided because I am talking about something. It is not. So one should know when not to do. This is extremely important, and this has been very nicely discussed. And I think Siddharth has done a wonderful job. He has given the overview of all these debates so nicely that really I think he was not confused since the beginning. And I think we have improved after listening his talk. Okay, thank you very much.
We are motivated too, sir.
Yeah, and thank you very much for this organizing team who has organized this debate so nicely. Okay, we did not see any fire, work here, but still it was sweet and very, very knowledgeable.
Yes,
I appreciate.
It was already instructed by Shailesh not to.
That is Shailesh's decision of case selection. Case selection like surgeon selection. He said people who are old enough not to fight.
Yeah.
Thank you. Over to Javed, our intense man who always helps us with our academics. Javed, where are you?
Thank you, sir. Dr. Ajit Shinde, sir, the president of MOA, Dr. Kanna, sir, president of Pune Orthopedic Society, academic chair for this event, Dr. Raghav Datt, sir, and the course director, Dr. Shailesh sir, and all the esteemed and stellar faculty members and panelists. A warm good evening to all of you. On the outset, I hope you all are safe, strong, and healthy. Today, we are deeply saddened by the loss of our lovable and dearest Dr. Ramesh Kumar sir, who will always be remembered for his contributions, especially to Safdarjung Hospital. And these are some challenging times we all are living in. But we are all glad that one of the COVID opportunities bringing out is these wonderful webinar events, these academic events which is there. And true to that, as Raghav Datt has said, any time for any spine surgeons meeting or academic events never ceases to fascinate us. And true to that, we have always been associated in wherever possible way we can. Even in COVID times, best to our abilities, whenever there is a reference, we try to provide the best quality services to all your patients whom we recommend Terifrac and Olimab. I have a humble submission to make here. We thank you over the years for the associations with all the spine surgeons of the country, for the patronage you have been given to Terifrac and Olimab. And in reciprocation, we can always assure you that we are always open with both the arms for any partnership with academic events like this as well. Right? Thank you so much for all your support. Stay safe,
Thanks,
stay
Javed.
healthy. Thanks, and may God's mercy and blessing be upon all of us. Please do take care of yourself. Thank you.
Thank you all. Thank you.
Thank you all for this.
Thank you. Thank you, everyone.
Thank you.
Thank
you. Thank you.
Bye.
Good night. Good night.